any interest in spending Friday skiing at Crystal Mountain up in Michigan?
Oh, wow. I haven't been skiing in years, but that actually sounds really fun. If you promise not to laugh at me when I fall.
You know, I can't promise you that, but I will help you get back up again.
It's a deal.
To shift before, so we'd have. Hey, Carl, is there a great place?
Good morning, and thank you all for joining the Iowa ACC ECHO lecture series. This is a follow-up to the virtual lectures that we did last year of general cardiology and interventional cardiology. At this time, I would like to welcome you to the lecture series along with the rest of my planning committee. Jay Parek and Kofi Osei, my FIT co-chairs, Shubhadeep Roy, our FIT social media representative, and Autumn McGill, our chapter executive. It's our pleasure to have you join us this morning. Just a few reminders as we start the lecture series. Reminders to keep yourself muted at all times. Please feel free to ask any questions, keep it interactive, keep posting on the chat any questions you want to ask the speaker. Jay will be, and Kofi will be kind of moderating the Q&A at the end of the lecture. So please feel free to post what you want. We also welcome any feedback. If you have any suggestions about how we can do it differently, how we can do it better, please let us know. In addition, there have been quite a few questions if this is going to be recorded or not. As long as the speakers give us permission, we will be recording these lectures and we'll be uploading them. So at this time, I just want to share with you the Iowa ACC the website, the Iowa ACC website. So under iowaacc.org, if you go to fellow education lectures, we have the fellow education board prep lectures from last year. And anybody who has taken the ECHO boards will tell you that a lot of questions actually reflect on your general cardiology knowledge. So I would highly encourage, if you're planning to take your ECHO boards this year, I would highly encourage you to go through these lectures or some other board review of general cardiology, whatever works for you. But that will be very beneficial for you. So without further ado, and again, this is where, if you go to the website again, sorry, under fellow education, ECHO board prep lectures, this is where our slides and our videos will be uploaded, hopefully very soon, early next week. And we'll post the link in the chat, and we'll include it in the future emails, so you know where to look for it. But it is under fellow education under Iowa ACC. So without further delay, I'd like to introduce our first speaker, Dr. Georgios Christodoulidis. Dr. Christodoulidis is an assistant professor in the Division of Cardiology at the University of Iowa Hospitals and Clinics. He did his medical degree at the University of Patras Medical School in Greece, and then his internal medicine residency in Winthrop University Hospital in New York, and cardiology fellowship at Guthrie Clinic in Philadelphia. He did a cardiac imaging fellowship at Mount Sinai, St. Luke's in New York. He's been on our faculty for quite a few years. He really enjoys teaching our fellows, and we appreciate him sharing his expertise with us. He is going to be doing 2 talks for us today. He's going to be talking about a normal TEE, and he's going to be talking about diastolic dysfunction. So again, if you have any questions, please feel free to put them up on the chat. Thank you for joining us. Georgios, you can take over.
Okay. Good morning, everyone. Mahi, thank you for the introduction and for including me in those beautiful lectures that you're organizing. Jay, can you all hear me well?
No, we're hearing a little resound.
Can you talk again, Dr. Georgios?
Can you hear me better now, Jay?
There is slight sound at the background, but otherwise your voice is clear. It's just that slight sound in the background.
Okay. I'm not sure why we have that sound at the back, but I guess we can start. I don't have anything else going on here, so not sure if there is a system error here. All right. So we're going to start, as we said, I'm Dr. Georgios Christodoulidis. I'm one of the staff here at the University of Iowa. welcome everyone. We're going to be starting our lecture series with the normal transesophageal examination. So the main document that I use for this presentation, no surprises, is the ACC guidelines from the 2013 actually. Another document that I use, and I'm going to encourage everyone that, you know, when you have the time, you can also use it also, is the, there is a beautiful website from the University of Toronto. People there did a great job on this website. It's actually a free website, so everyone can join that. They have beautiful views and detailed explanations. And I have used some of their animations that they have there in trying to show you guys better what they are trying to do. All right, so both of those two things I'm highly encouraging you that you should be using them while you're reading about TEs. Okay, let's go. So introduction. TE, as you know, is a critically important cardiovascular imaging modality, and that's why we're talking about it. And why is that? Because the proximity of the esophagus to much of the heart and the great vessels make it an excellent ultrasonic window. You can therefore use a higher frequency transducer, and you can have excellent spatial and spatial resolution, and therefore provide additional and more accurate information than TT, especially in regard to structures. Some general indications for TE. One, as we said, that whenever you need some detailed evaluations that are actually on the far field for the TT, example would be the aorta if you are looking for dissection, the left atrial appendage if you are looking for a thrombus. And then if you are doing a prosthetic heart valve evaluation, or for these purposes, any type of evaluation that you are looking for endocarditis, T would be a great option. And then if you have prosthetic valves and you are looking for paravalvular abscess, then there is, you know, very unlikely to be able to see it, you know, with just a single TT. And then, you know, there is a mixed bag of any time that you are doing a TT and it's a very suboptimal quality and you really want some information about the heart and valve function, you know, such as in patients with ventilators, chest wall injuries, etc., then you can always consider TE. Sure, there is some anesthesiologists on our audience. As you know, intraoperative TE is very useful, especially in all heart procedures. And then, of course, helping out our interventional friends, especially when you're, as you guys know, whenever you're doing Watchman procedures, mitral clips, the transesophageal echo during the procedure is actually essential. And finally, sometimes in critical ill patients that you are unable to get some images. All right. Now, contraindications. So I think this is important for you guys that are taking the boards because, you know, you want to help people with giving more information, but then you don't want to cause problems, right? You definitely need to know the absolute contraindications because that's the time that you're going to stop and you're just not going to proceed with the procedure unless you fix things, right? And what are those? If you have, and they're, you know, pretty obvious actually, but just kind of reminding everyone, if you have a perforated viscous, esophageal stricture, esophageal tumor, esophageal perforation, esophageal diverticulum is an important one, and of course active GI bleeding. I don't think that you would be doing a T while you have an active GI bleed, right? Now, then there is the relative contraindications. The point with that, you should be well aware of those, but those are not like, you know, we're not doing it. Those are more like you pause, you think of the risks and benefits, and then you decide if you need to do them, right? So most of them are like GI related, you know, there is GI, upper GI surgery, recent GI bleed, Barrett's, dysphagia, hiatal hernia, varices, and then there is some, or esophagitis, and then there is also some issues with the coagulopathies, thrombocytopenia, and those kind of things. And finally, some restriction of neck mobility is also an issue that you may consider. And, you know, if you think that's a problem, you may also consider getting a GI evaluation before your procedure. So, you know, there is no shame of getting some help before proceeding instead of, you know, proceeding and causing problems. All right, moving along. Some complications. Generally, T is a very safe procedure, but you know, you as fellows, you're going to get consent for the patients, and you need to be well aware of the complications, and you know, actually mention to the patient that you know it's rare, but things can go wrong. The things that mortality would be extremely rare, you know, less than one in 1,000. The major complication that you need to be aware of is the major bleeding and or esophageal perforation. Again, pretty rare, but they can happen. And I guess if you do enough of them, you may get into that problem. Another one that, I thought it was extremely rare, but actually did happen to me once is actually tracheal intubation. I'm going to share my experience there just so you guys are aware if that happens to you, what you need to do. And essentially what happened, one as kind of an anecdotal evidence is that patient was a post-stroke patient, and talking with my other colleagues of mine, that's when that happens, usually someone that doesn't protect their airway that well, right? And then what's going to happen is that you're going to do the intubation and can even go smoothly. This case actually went smoothly intubation, but the problem is that the patient became very uncomfortable. He became hypoxic. And then you go to advance the probe and you get to about 20 centimeters and then you get stuck there. Don't push more. That's everything is telling you that you went the wrong way. You're not able to get any images. So what you do, you just come out. Then you do it again and then everything goes smoothly. And clearly it was a tracheal intubation. So be aware of that. It's not that uncommon, I guess. Now, moving along, patient preparation. Important to remember, especially as fellows, that you make sure that everything is ready before doing the procedure. So NPO with other than liquids for 6 hours, nothing per mouth for 3 hours. The patient can take their medication, so that's important. So they should take their medications with a small sip of water. Remember, if there is delayed gastric emptying or tube feeds and those kind of things, you may want to have longer periods of fasting. And very important that you need to have IV access because there is medications going to be giving, right? Moving along, sedation. So starting, the first thing you do is give a little bit of lidocaine to anesthetize the oropharynx. And then we usually, for sedation, we use the classic things that we use is Versed and fentanyl. For usual size patients, I start with a 2 of Versed 50 of fentanyl. If they are small size women, older, I may go with 1 in 25, and then repeat every about 3 to 5 minutes, basically. Generally check the blood pressure also, because with sedation, blood pressure can come down. Remember that if for whatever reason you decide you want to do propofol for anesthesia, then you have to have anesthesia. You cannot do that by yourself. And another important thing is remember that you may need to give reversal agents. It shouldn't be the standard and should rarely be used, but if you need to use them, especially if there is respiratory depression for whatever reason after giving the sedation, flumazenil would be the reversal for benzos and naloxone for opioids. One good thing to remember is what are the doses. I don't think that you are going to be asked for your boards, but I think it's a very useful information to have handy in case that this happen. So for flumazenil is 0.2 milligrams and you give the dose over 15 seconds and you may repeat every 1 minute for a max dose of 1. And then for naloxone, you probably have used that more in the ICU setting, especially if you have patients with overdoses. You administer 0.02 IV every minute until you get your reversal. Now, the important thing with naloxone is that the duration is 15 to 13 minutes. So if you have to use that, be mindful that you may need to repeat it later on. All right. So good to remember your reversal agents in case you need them. Now, moving along to the meat of this discussion, we're going to start considering now how you're going to be doing the procedure. Some basic orientation. I know it's very basic, but I'm not sure if we have some first year fellows that haven't done too many. So I'm going to make sure that you have that under our belt. So we always assume that the patient is in the supine standard anatomic position. All right. When I say superior, I mean towards the head. When we say inferior, I mean towards the feet. Posterior is towards the spine. Anterior is towards the sternum. And then the right and left denote patient's right and left. All right. So remember that one. So everything related to orientation is the patient right and left. So if you are holding the probe and I tell you turn right, for your side it's going to be turn left, but for patient it's going to be turn right because they're looking towards you, right? So don't get confused with that, and make sure you are doing the right things. Moving along, so this is your probe here, right? So when you are advancing, you're going further down to the esophagus. When you are withdrawing, you're coming up. This is the turn right that I was saying, right towards right side of the patient. So you're going to see more of the right sided structures of the patient, right? And then turn left would be this side, exact opposite. Then as you know, your probe has a different angle, so you can change from 0 to 180 and change your planes. And then you have the big wheel, which essentially when you're doing anti-flex or you are going to be moving anterior to the patient. And when you are doing retroflex or extension, I usually use the word extension so you don't get confused, then it's going to be posterior to the patient. And then you have the small wheel, and then there is the flex. With the small wheel, you do flex to the right and flex to the left. All right. And then those are your standard windows that you're going to use. That's your upper esophageal right here, your mid esophageal, which is the mid of the exam, as you guys know, right here. Then you have the transgastric image here, and then you also have the deep transgastric that you try to pretty much come close to the apex, basically, and take your and use that as your imaging window. All right. Now, moving along, we're going to start with the different structures. So just a little bit of thoughts that I have in regard to that. Obviously, you are doing the normal transesophageal exam, and I elected that I want to give you like a more three-dimensional idea of what you're actually doing, and trying, you can kind of get all the images in your head if you do a lot of TEs, but if you really want to understand TE, you have to start thinking in a three-dimensional. And this is where I actually think that website that I mentioned at the beginning from the University of Toronto is actually very useful, because it actually gives you those nice diagrams, and I'm using some of those here, so kind of understand what exactly you are doing. And secondary, initially I was thinking to show you like a perfect young patient with all normal, but that you can always see pretty much as I said, at that University of Toronto. So I'm using mostly normals, but I'm using some cases that there is some abnormalities, so we can keep it a little bit more interactive. And I'm also using some cases that you can actually, the images could use some manipulations, and I'm going to explain you what manipulation you should be doing in those cases, especially in some, more difficult use. All right. So starting, when you go in, you usually start with the mid-esophageal. I usually start my exam with the mid-esophageal. Some people start with transgastric, I start with mid-esophageal. So your first mid-esophageal view that you're gonna get is gonna be your 5-chamber, usually at around 30 centimeter. You may, anywhere between 0 to 10 degrees of rotation. And what you are trying to see basically is you wanna make sure that you have the aorta in your, the LVOT and the proximal aortic root in your view on top of the your classic 4 chambers. And this is the images from the University of Toronto, actually, that they're basically showing what is your cut here, right? And that's an open up, basically showing what you are seeing here, which is your 5-chamber. And essentially in your orientation, this is what you are seeing basically, right? This is your LA, LV, your LVOT with the root, and the RV and array, right? And that would be your classic imaging. So if you wanted an image of that, that would be something similar to that, right? One thing to note in this view, this is a view that I already started focusing on the mitral valve, right? So you see that I'm cutting the LV short. Even though the LV is nicely open here, I decrease my depth and I'm cutting the LV short there. If you wanted to see the full LV, you have to increase the depth there, right? Moving along, a very common view is the 4-chamber view. So what you are doing here, you are on the 5-chamber, you just advance a little bit more, right? And you advance until the aortic root disappears, basically, right? You may need to increase your ankle anywhere between 0 to 20. One trick that I'm going to say here, if you, especially at the initial view that you're trying to see the LV function, you may need to retroflex a little bit your probe, essentially extend the probe so you open up the LV, right? And this again is our nice diagrams. So basically, again, this is your imaging view here, right? So this is what you're going to be seeing in your 4-chamber. If you read it right, you see the LV apex is normal. That kind of looks like the 4-chamber from the transthoracic. So that's your anterolateral wall. This is your inferoseptum, your RV. Here you're going to be seeing the septal tricuspid leaf, usually septal with the anterior tricuspid valve leaflet. Again, it's kind of similar to what you are seeing with the transthoracic, right? And again, this is the kind of the schematic of what you are supposed to be seeing. So again, if you wanted to see an image of that, this is the 4-chamber here. What I usually do is once I get kind of like trying to optimize and do your procedure as as efficient as possible, I usually get my 4-chamber And then because I'm using that for my function, I also use a biplane. So it gives me another two. So you have the 4-chamber and the 2-chamber at the same time. And because the function is normal is the case, I'm not going to spend too much time on focusing on a 4-chamber, on a 2-chamber also, right? I already have the function and it looks normal. Now, as I was saying, I chose some images that there is a problem with them. I'm sure that you guys encounter that a lot. You can see that there is those white things that they're coming in and out in my plane here. This is not a crystal black view. What happens, there is a little bit of air that is cutting between my transducer, in the esophagus, between my transducer and the images. So the way that you kind of go around that, you go a little bit up and down, so you kind of break up that air that is in between, and you get a better window, basically, right? So once I take that, then I usually finish up my function with going a little bit higher angle, so I get like all of the walls of the ventricle. And then I change my focus and I start focusing on the mitral valve and different angulations. And this is essentially what I did here. This is like a very, I think it's the same actually image, which I just changed basically the depth and the focus. And now I'm changing the depth and the focus to focus on the mitral valve. I also went up a little bit up and down, and then you break that bubble, and that's not a problem. So you can see much better the mitral leaflets here, right? So here, this would be the anterior mitral leaflet. This would be the posterior mitral leaflet. And from the tricuspid, usually this is going to be the septal, and most likely this is going to be the anterior. All right. In each view, and different people do it differently, but for me, from here, I'm going to proceed with the mitral valve evaluation. So I do structure, and then I throw color on this. I haven't shown color. I'm not going to be showing color picture. It's kind of intuitive for a matter of timing. Now, from the 0 to 10 degrees, then you go ahead and do your mitral commissural view. And what you do essentially, you stay on the mitral valve and then just increase the angle. Usually around 15 degrees, you are going to get your mitral commissural view. What you're really looking for is to get that, as we call it, the trap door view. And you are essentially seeing at the P3, A2, P1, starting from left to right. However, as I'm going to discuss to you later on, when you are getting the scallops of the mitral valve more in detail, you may see different scallops in the middle. So P3 and P1 is the standard ones, but depending of where you went, you may see just A2, or you may see a big portion of the anterior leaflet, A3, A2, A1. And I'll explain to you why is that the case, right? Now, from this position, and that's a useful thing if you are really interested in the mitral valve, what you can do, you can actually use your small wheel and turn leftwards to image the length of the posterior leaflet, or you can turn rightward and imaging the length of the anterior leaflet. All right, that's if you want more detailed evaluation. And this is what you are talking about. This is right now where you are cutting from, right? And what you are seeing here is your, again, your LV in the backside, but you're really focusing on the mitral leaflet, right? And as we said, the P3 and the P1, and the A2 that is going to be coming in the middle, the trapdoor as we call it. And if you wanted to see the image here, this is what I think a good image is here. Again, you can see, I don't know if you see that, that's your trapdoor that is coming in and out. All right.
Hey, Dr. Georgios,
Yes.
sorry to interrupt. Can you use your mouse? The audience is not able to see the marker where you're pointing to the anterior or mitral leaflets or the posterior mitral.
Oh, really?
Yeah.
Can you see my mouse here?
No, I can't.
Wow, I don't know why, because I can't see mine. Can you see my mouse here?
No, we can't.
Wow.
If you can't fix it, that's fine. We can keep moving along.
I'm sorry, guys. I'm not sure, because I can sure see my mouse. I'm not sure why it's not sharing with you guys as a screen.
That's fine.
Oh, are you seeing it now?
Yeah, we can see it now.
Oh,
yeah.
Okay. So let me go back. So that was the anterior and posterior, as you were saying.
Thank you very much.
And then, as we said, your the mitral scallops in the images from with the P3 and the P1 from left to right, right? So left to right, P3 and P1, and the trapdoor, which would be the anterior, is this one here. All right, you guys can see it now? Okay.
Yes.
All right, excellent. Sorry about that. The moving along to your 2-chamber, again, you keep your focus on your mitral valve, and you keep going up on the angles. One trick I'm going to say, especially for the more junior fellows, don't just, you have a view, don't just lose the view, go to the 90 and try to view it. While you're going up, keep your mitral view in the view or whatever other structure you are evaluating, right? So it's actually a very useful view. The 19-degree, you're seeing the anterior and posterior wall of the ventricle, but again, we're focusing on the mitral valve in this case. So you're going to be seeing the P3, and then you're going to be seeing the entire anterior leaflet, A3, A2, A1. And you may also see the coronary sinus and short axis orientation. All right, so this is what you are seeing here. Again, this is your the plane what you are cutting here, and this is your anterior and inferior wall, your coronary sinus. Again, focusing a little bit on the mitral leaflet. This is the entire mitral leaflet, and this is your posterior, just a small piece of it, right? You might, I forgot to mention that you might be seeing a little bit of the start to see some of part of the appendage here. I'm going to talk about more in detail about the appendage later on. And this is your a classic view. Again, focus for the mitral valve. As you see, I'm cutting down the LV, anterior leaflet, posterior, A1, A2, A3, and the P3, right? And again, don't worry, I'm going to show you a little bit more in detail the mitral valve evaluation to understand what is happening, because I think it's a testable field. All right. Moving along, again, you're now at 90, you go another 30 up, you go around 120 to 130, you get your mesoesophageal long axis view. That kind of reminds you the same orientation as the long axis view at the 3-chamber with your transthoracic. The leaflets that you're going to be seeing here is going to be the P2 and A2. You'll also be seeing part of the membranous septum and the part of the RV wall, right? And again, this is your nice image that is showing what you are cutting through. This is all the structures that you're going to be seeing. You see your LVOT, your aortic valve here, anterior and posterior leaflet, right? And if you were to see it here, again, this is going to be your A2, your P2, right? You see your aortic valve, but I'm not focused on the aortic valve here. I'm going to show it to you later on about that one. And of course, as I said, subsequently, you're going to put some color onto it. You see there is normal mobility, normal thickness, and all that stuff. Clearly and nicely seeing. If there was a vegetation, you'd be able to see it. All right, so we talked now, a good time after we do all these things is kind of explain a little bit the leaflets and the scallops of the mitral valve. All right, this is difficult, guys. Let me be honest with you, because even though I'm going to be showing you those things here, a lot of times you're not going to be sure what exactly you are seeing. In order to be confident what you are taking, you have to, one trick, what I did initially was, what I was learning is go look at, for example, at any website that you can find the exact normals and try to recreate that exact normal view. Just because you are on the 0 degree, that does not mean that you are seeing what I'm showing you here, especially the very tricky one is actually the mitral commissural view. But even the 19-degree view, I can ensure you a lot of times you think that you're on the right 90 view and you're not taking. But what the concept is if you are on the right 0 view, you are cutting through here, right? So if you're cutting through here, you're going to find a little bit of A3. That's why you see it here. Then you see A2, you see it here. Then you keep cutting P2. You see this is your P2 here, right? So you're cutting P2, and then you finally cut P1. You know, one thing to always remember, the ones that they are usually attached together, they're actually the same type of scallops, right? So if A2 is going to attach with the P2, right? Now, if you do the mesoesophageal, right, that's a 45-degree view. But here is what is the trick, right? You are cutting through here, right? So P1 right there, right? Then once you cut a little bit of the P1, then you go into the anterior leaflet. And the trick here is, where is your line? If you are cutting through at the very basis here, you're going to be seeing that A1, A2, A3, right? But if you're a little bit more in the front, you're only going to be seeing this A2 coming in, actually, right? You're still going to be seeing P1 and P3, right? Because this is what you're cutting here. But if you're cutting here, it's going to be P1, A2, P3. If you're cutting here, it's going to be P1, A1, A2, A3, P3, right? So it gets a little bit more complicated. 90 actually gets a little bit easier. So you cut from here, right? So you start A1, sorry, A1, A2, A3, and then P3, right? Now, oh, sorry, I'm showing you wrong. Excuse me. So that's why I was like,
90 is the
that's
other
right.
one.
Yeah. Are you, all right. So this is the this is your line that you're cutting here, right? So in the 90, you are cutting through here, right? So again, A1, A2, A3, and then P3. Clear? And then finally, this one is probably the easier one, and that's the one that, now the problem is that if you are not angulating well, what you're trying to, you have to make sure that you created like a long anterior leaflet. So that's A1, A2, A3. So look at the image that I kind of showed you before. Oh, it's not playing right now. Let me see it here. See? It has to be a long one. If it's not, if you didn't create the long one with a short one here, then maybe you're not doing the right thing there. That's why I'm saying it's a little bit tricky sometimes, right? And then finally, this one is probably the easiest one, that you're coming exactly from here, and this would be your A2 and P2. All right, pretty complicated actually, but unfortunately, we as cardiology, we like complicated, and you might be asked in the in the exam. So you should probably have an idea of what's going on. Now, the gift of God to the cardiology was actually to the was basically the 3D echo, right? Because, you know, with all those complicated things that I just told you, you can make your orientation much easier if you do a 3D acquisition, right? And how do you do that? What do? You basically first take your you optimize first your tuned images. That's probably the most important thing to get a good 3D image. Optimize your tuned image, right? You really focus on the structures that you're interested. Then you do a biplane, right? A classic view that we use, you can use any view by the way, but a classic view that you use is actually the 113 degree. And the reason that is that your aorta is really nice in your view, and that's going to help your orientation. So you do your biplane here, then you press your 3D zoom button, right? Then you rotate down and you get your mitral valve to come and face. And then there is a button that is called rotate Z. So you basically rotate this thing here to bring the aorta on top. So what you're trying to do is you are trying to recreate what we call the surgeon's view. So basically you have opened the heart and you are looking on top of the heart down. So if you create that view, then you are going to know so that's why you want to have your aorta there in the view. So it helps you with your orientation. And then from here, if you want to, and it's not very classically used, but you can also rotate a 180 degrees and see the mitral valve from below. But the classic view that we really need to know is this one here, all right? With this opportunity, I want to tell you guys that, you know, especially if you are more like a 30-year fellow, you have to start learning of how to use the knobology of the machine, because, you know, once you become a staff, you're going to be able to do it by yourself. So just because your staff is doing that, then you have to learn to do it by yourself as soon you're going to be on the other side of the probe, right? And if you do everything right, you're going to get an image like that, nice and beautiful. And you can see your anterior leaflet and your posterior leaflet. And this one is going to be A1, A2, A3, P1, P2, P3, right? And essentially on the lateral side is going to be A1, and on the more septal is going to be the 3, right? And there is no way, if you get good images, there is no way to confuse things. It's infinitely much better. And it's also much better for the when you are explaining things to your cardiothoracic surgeons. Much easier. All right, so get used to the 3D. Is a very useful tool. On top of that, I don't have an image here, but what you can do, you can actually throw some color if you need to, and it can actually show whether the if you do a good job with that, you can actually show where the jet is coming from, and ensure that, you know, there is no perforations and those kind of things. So if you get a good 3D with color, it's very useful to make sure that there is no perforation of the leaflet. Because sometimes with the 2D, you might be confused that there is a perforation, but especially in the commissural view, you think that you are seeing 2 jets, but you are just cutting the jet in 2 different areas, and it's the same jet that you are just cutting, you know, discontinuously, basically. All right, moving along, we're done with the mitral valve, which is perhaps the toughest part here. And we're coming now to, you are focusing on the aortic valve. So you're on that 130, 135 degree. What you do, you change a little bit your depth, your focus, and you basically get a focused view of the aortic valve and the aortic annulus. Very useful view in order to do all of your measurements for the aortic valve, and it's also a very useful view, especially if you are looking for endocarditis of the aortic valve. As you know, kind of the same idea with the transthoracic. This leaflet here is going to be the far field leaflet is going to be your right cusp. This one here, at this point, you don't really know whether it's your left or the non-coronary. We're going to discuss that a little bit further down the line, right? And this is kind of the view that I was talking to you about. So you are focused on the root here. Again, this is the right cusp, and this is your left or non. We don't know at this point. All right. And again, of course, you can put some color there and see if there is any regurgitation or anything like that. Now, one interesting view that I've noticed that sometimes our fellows have some difficulty getting is the mediasophageal ascending aorta long axis view. So how do you do that? You are on your 130 degrees of the aortic valve. So what you do, you pull out your probe and until you start seeing your right PA, right? And you want to start seeing your right PA because you want to use that as your ultrasonic window, basically, and further image the ascending aorta. And then once you do that, you're actually dial down on your angle from 130, you go to low hundreds, 100, 1.5 or so. And then you also need to rotate a little bit to the right. And then essentially what you do, you're opening up your aorta. All right. And this is exactly what you are doing. So as you see, we came back, you see here, we came back a little bit. We were a little bit lower, it came back a little bit. This is your RPA here. And what you are doing, you are going through the arch. So your window is not the LA anymore. It's actually your RPA here, right? And then you open your aorta and you're supposed to see something like that here. It's a very useful view when you're evaluating the size of the aorta or when you are looking for dissection. So get used to that view because you don't want to be doing it for the first time when you're doing a dissection study and you are sweating on it, all right? Now, I'm showing you this view. This is actually not a great view, and there is a reason why I'm doing that. So remember what I was saying, that you're gonna be using the RPA as your window, right? So the mistake that we have here, even though you are seeing, a pretty decent size, and if I stop it, I can clearly see a decent size of the aorta, this is not a great view. So in order to optimize the view, what you need to do is you come out, before you tune down on your ankle, what you needed to do is to come out a little bit more. So you use this as the center of your screen, right? So if you go back, you see what I'm saying here? The center of the screen is here, the window is the RPA, and then it opens that a little bit more, right? Any questions here, guys? No, let's move along. Now, from here, I usually continue with my short axis evaluation of the aorta. So what you do, you go back to your, so as I said, you came out a little bit, so you go back to your aortic valve level and then dial down to usually around 45 degrees that you are going to get the mediasophageal short axis view, right? You are going to identify all the cusps. I'm sure you know, but we're going to repeat that anyway. Remember, this is actually a really good view to assess the intraatrial septum. This is actually a very useful view for the interventional cardiologist. You really want to see if there is a ring if you are looking to do a percutaneous closure. All right. Now, on your far field, you're also going to be seeing a little bit of the RVOT and the pneumonic valve, but we're going to talk about that later on. If for whatever reason you are going to be you want to see the origins of the coronaries, you can see them. Sometimes you are looking for aneurysms. You can see some crazy cases, Kawasaki and those kind of things. All right. So this is what you are doing. As you see, we change our orientation or cutting the short axis essentially at the base of the heart. So what you are seeing here, LA, RA, deep is going to be your RVOT with a pneumonic valve, and the center of the screen is going to be your aortic valve. So from here, what is going to be your leaflets? Your leaflets essentially use the orientation, the other structures as your friend, right? I'm sure that intraatrial septum is here, right? So if you know that's the intraatrial septum, that has to be the non-coronary cusp. This is your RVOT, so this has to be the right cusp. And then by definition, there is only one left, so that's the left cusp, right? Nice and easy. And, if you want to get a good image of that, that would be what we said here. So again, this is going to be your left, this is going to be your right, and this is going to be your none. All right, so let's see if everyone is awake. I choose this view not because it's a perfect view of the aortic valve, but there is something else that is going on here. So does anyone from the audience is noticing anything here? Anyone, guys? You guys see something abnormal here? Anything worrisome that you want to, further evaluate?
There is a echogenic structure in the atrium near the interatrial.
This one here. Yeah, so what is here? That's a good point also. That's not what I was pointing out, but this is probably a prominent eustachian valve, right? But there is also something more here, right?
ASD.
Good. So this is a pretty obvious ASD here, right? To be honest, when I was doing this study, I knew in advance that there was a shunting in the atrial septum, so there was no surprise to me here. And in case you are wondering, don't take my word that it's just an ASD. So anytime you see a hole, this one is a very obvious one, and I had no question even before I put color, because it's not just that you see the hole, you can even see that they are moving like independently to each other, right? But you put a little bit of color, I think there is no question that there is an ASD. This is a condom ASD, right? Just to make sure that you guys are awake and I'm not, too boring with my normal studies. Moving along. So once you are done with the aortic valve, there is a couple of ways you can go ahead. Generally, I usually proceed with evaluating the appendage. Some people want to finish up the valves. There is no right or wrong. It's whatever you get used to. So I take this opportunity to say that you should create a standard flow to your views and kind of stick to the flow so you don't forget on things. Anyways, so let's say that you wanted to finish up the valves. So what you do is, remember when I was showing the tricuspid valve on the initial images, you didn't really see well the tricuspid valve. So if you're really interested in tricuspid evaluation, if there is a vegetation, or if you want to see if there is like a lead and vegetation on the lead and those kind of things, you actually, what you want to do, you get your fourth chamber and then you rotate a little bit more to the right of the patient to optimize the right heart evaluation, right? And then because the tricuspid valve is a little bit more apically displaced, you may need to further advance your probe, right? And then once you get the 0 degree, then you can pretty much do as much detailed evaluation with different angles as needed. At the very least, you want to do the 0 degrees and the 50 to 70 degrees, which I'm going to show right after. So you can see here, basically what I did is, again, a 4 chamber, but you see I'm cutting out the LV. I don't care, I already saw the LV. And I'm focusing more on the tricuspid valve. As I said, this is the septal leaflet, and this is most likely part of the anterior leaflet there, right? And you can also do 3D on this picture if you do good enough. Then, as I said, you can, if you want to do more detail, you can do 30 degrees of the tricuspid, 40 or so. But at the very least, you should be doing the RV inflow and outflow view, which is usually at around 50 to 70. I usually get it a little bit higher angles, like 70s to 80s. I get this the tricuspid RV outflow view. And this is essentially an off-axis view of the view that I showed you before for the aortic valve, right? And it's an off-axis because I went with a little bit higher with my angulation and I'm a little bit more rightwards rotated, right? So if you are doing that, you're going to be seeing your aortic valve in the middle, but you're not going to be seeing those nice 3 cusps. It's going to be kind of like off-axis, and you're going to be focusing on your pulmonic valve here and your aortic valve here. Gets tricky of which leaflets of the tricuspid you are seeing depending on how you angulate, right? So if you angulate a little bit upwards, you might be seeing both anterior leaflets. It's not standard. You're going to be seeing anterior tricuspid valve leaflet and posterior tricuspid leaflet. Don't take that to the bank, because if you're like a little bit more upwards, you might be seeing anterior and cutting again the anterior in different point. All right, and view that you're going to see here is right here. As you see, actually in this patient, I ended up needing going even higher. It's actually 19 degrees here, but people don't read books. So the angulations that they are saying are a little bit generic, right? But you have your pulmonic valve here and you have your anterior, tricuspid leaflet here. And I think this actually, I'm cutting up anterior here actually. It gets tricky, and again, 3D can be very useful in those situations, or, multiplanar evaluation actually. It's probably the way to go. Moving along from here, you just go a little bit higher in your angle at around 100 degrees, and you get your mid-esophageal bicaval view. This is a great view to evaluate the septum, basically. That's one of the ones that you really want to focus on if you're looking for a PFO and those kind of things. Remember to evaluate for sinus venosus ASD. If you don't, remember this one. If you don't look for a sinus venosus ASD, you are not going to find a sinus venosus ASD. That's a rule. All right. If you just do the standard plane, you are not going to find it. You have to, I'm going to show you, you need to rotate a little bit more towards the SVC to find it. All right. So again, this is your beautiful image here showing that you are cutting through the two cava. That's why it's called bicaval, right? SVC, IVC, and the atrium in the middle. And then you're having triatrial septum here. And if you are to do it here, this is what you're going to be getting, right? SVC, IVC, the array. And you want to play around here and kind of thin out the septum here, right? You're kind of seeing it here, the thinning out the septum. What I was talking about the sinus venosus ASD here is basically what you want to do. You may want to rotate a little bit towards the SVC. I mean, obviously here there is no sinus venosus ASD or anything like that. But what you want to do is to rotate a little bit on that side and even maybe put color and make sure, remember, sinus venosus, basically the SVC is coming and instead of going just just draining here, it's kind of draining in both of them basically, right? So what you are going to see here, there's going to be that you're not going to have, you want to show that a little bit more and make sure that there's nothing missing here and the blood is going here and here also, right? Now, and I'm talking about the superior sinus venosus ASD. I've seen like 3-4 cases actually of that. Inferior sinus venosus ASD, very tough to evaluate. I've never seen an inferior sinus venosus on a TE. I have seen one on CT. I read CTs also. I don't think that you can easily find an inferior sinus. It's extremely rare and it's not going to be easy to see. Now here in this view, you also throw your do your bubble study, right? And you want to see if there is any crossing of the bubbles. You can also do bubbles on the 45 degrees that I showed before. Now here's the trigger I'm going to tell you. If you do the bubble and you see bubbles, right? Then you are wondering whether it's a PFO or ASD. By doing, you evaluate the whole septum in different angles, you can clearly see if there is a hole that's an ASD like the one that I showed you, or is it a flap and it's just a PFO. And generally, if it's a flap, what I try to show is I try to show an image where I can actually show them bubbles crossing through the flap. If you do that, then you are very confident that there's just a PFO. All right. You see bubbles crossing, always be mindful that you are not missing a sinus venosus ASD, especially if you're not seeing a flap and you are not seeing a clear secondum ASD. Okay, moving along. From here, one of the difficult parts for the transesophageal echo is finding the pulmonary veins. An easy way to find the right upper pulmonary vein, while you're on your bicaval view, you turn a little bit to the right and you're going very easy, you're going to see the right upper. And then once you get the right upper, you at the very least, you want to show 2 pulmonary veins on your exam. I usually for sure show the right upper and the left upper, but regardless, from the right upper, once you get the right upper at the 100 degrees angle, then you keep the right upper in your view. You may keep color going on there and you dial down while keeping your right upper in the view. And when you come around 13 degrees or so, you're going to start seeing a V that is showing basically the right upper and the right lower. Now, from the right upper, if you wanted to see the left upper, you actually turn to the left, or even easier when I'm going to show you later on, when you do your appendage evaluation, right above the appendage is going to be the left upper. So take this as the right upper here and then turn down and show the right lower. All right. Now, one small caveat about the pulmonary veins. I see a general comment that all pulmonary veins were visualized. That's not correct. You saw 4 pulmonary veins. Having read a ton of CTs, also there is a lot of variation in the pulmonary vein anatomy. As you know, 4 pulmonary veins is the standard, but I'll tell you that a very common variation is to have 3 pulmonary veins in the right. So essentially you have the right upper, the right lower, and then there is an accessory small pulmonary vein. So a lot of times you may be seeing that one and you see that you saw pulmonary veins, but then there was another right lower much bigger than the one that you saw. So that's one. The other thing, and it's a very annoying thing if you are looking for 2 pulmonary veins on the left, it's not uncommon that if you see it on CT, the left upper and the left lower, they have a joint origin. It's not that you have just one, it's both of them, but they have a joint origin at from the left atrium. So if you are imaging, you just see a big left vein there, and you're looking for the other and you cannot find it, but it's just that it was just a big one. And then, if you were to go a little bit further, they just, divert and they do their job from there, basically. All right, so it can get tricky, and unfortunately, you cannot know if you're not doing an axial imaging. You're not going to be able to know about that. Anyways, that's your right upper. That's an easy, that one that you got. We had the bicable, like just turn right. You put the color, and you can clearly see here, right? And obviously, you have to have red coming in, right, because the permanent veins coming to the LA, right? And then that would be your left upper. And as I said, the easiest way to find your left upper, this is your appendage here, obviously. This is your Coumadin ridge, and this is your left upper. And then from there, I got it like around 50s, and you go a little bit higher angles, and then sometimes around 100 degrees, especially if you use the small wheel and turn to the left, you are probably going to create that V shot that is going to show the left upper and the left lower. All right. Moving along, a very important, very, very important evaluation is going to be the left atrial appendage evaluation. You guys know that, do that a lot prior to cardioversions, right? So you can find your appendage somewhere anywhere between 50 to 90. You're going to be easy to find your appendage. I usually start at around 15 degrees, but a lot of people find it easier to the 80 to 19 degrees. You're on your 2-chamber. Most of the times you're already seeing the appendage, so you just need to turn a little bit more to the left and open up the appendage. And as I said, you are going to see the left superior right above the Coumadin ridge. What you really need to do here is the following. You need to change your focus. You need to change your depth. If you are looking for, if you are looking for a thrombus, right? Change your focus, change your depth, really focus on the appendage. And then most importantly, you need to do multiple views of the appendage, right? I was actually doing a case yesterday with one of our fellows. We got our first image at around 16 degrees. There was some smoke, but I was like, it looks some smoke, but it looks clean. Well, we kept going up on our angles. It was not clean at all. There was a clear thrombus. I will mention here that the higher degrees, that 135 degrees, is actually a little bit of a tough view to get, but it's very important. Make sure that when you get it, you probably need to turn while you are changing your ankle, and then you really need to show those you really need to open up the appendage, right, and show that there is no clot sitting at the depth of the appendage, because this is where usually the clot is sitting, basically. And this is exactly what we found yesterday on that case I was telling you about. It was in the 135 degrees, there was a clear clot. You may use biplane to delineate the anatomy, but remember, when you are using biplane, you are using a little bit of your temporal resolution. And if you are using, if you are looking for a small structure, you may not want to do that. So do the biplane to, to orient you. But when you really want to focus on a structure, you may want to use a more focused approach, right? And then you always, if you want to use some color Dopplers and a pulse wave to see if, if there is any, you want to see the emptying velocities. And finally, if you need to, you may even use echo contrast, just 1 cc, and take some further images. So again, remember, multiple views of the appendage is critical. So this is a classic view. This is around 19 degrees. You see right nicely here the appendage, but this is just one image. You need much more than that. And that's, I got it here at 17 degrees. That's a normal looking appendage. You can see that it's contracting well. And, from there, you do all of the rest of the evaluation. Now, moving along, some more difficult views, actually. Transgastric can get a little bit more tricky. So kind of some things that I tell to the fellows, always get your LV in the middle. So LV in the middle in the mid-esophageal view, and then keep the LV in your view and start fishing your way down. Because, once you get into the stomach, you're lost and you're looking for the LV, not a good idea. But if you keep it continuously, your view, keep down, lower esophageal, you're going to start seeing the coronary sinus, boom, you go into the LV, into the stomach, you keep seeing the LV, and then you optimize from there, right? You usually want to change your settings to pen, and what you are essentially doing, you're basically changing the frequency of your transducer because you have more depth. And once you get in there and you start seeing your LV, what you need to do is you anti-flex, so you kind of hug the wall of the stomach and you start getting your image. And if you do that right, you're gonna see your mitral valve, that classic fish mouth, right? So this is what you are doing. You're in the stomach, so your transducer is here and it's coming upwards. So what you're gonna be seeing here is you're gonna be your anterior mitral leaflet, your posterior mitral leaflet here. Remember that because your transducer in the bottom of your heart, this is gonna be the inferior side here, right? This is gonna be inferior, this is gonna be anterior, right? And you're gonna be seeing something like that, and that's the view here, right? So remember, this is inferior and this is anterior, right? So, and this is your anterior part of the anterior leaflet, posterior leaflet. From here, I usually do it bicebal. You can always do the 19 degrees, and I'm gonna mention that, but you can always also do a biplane here, and gives you your long axis of the LV. As you see here on the far field, you can actually see the appendage also, but of course, this is not a good view. Your appendage on the far field, so that's not a good view to evaluate for clots and those kind of things, right? Now, from there, if you want to further evaluate the function, I'm sure our anesthesiology friends are going to know that even better. That's their main view. The transgastric mid-papillary view is actually your main view to evaluate the size of the size and function and of the LV. So what you do basically, you advance it a little bit further. So you get out, you take out that fish mouth, but you're actually essentially start seeing the papillary muscles basically, right? And then once you get the view with the papillary muscles, you can further advance and get more apical views, right? So this is what you are doing here. So short axis, again, this is your inferior side, this is your anterior, this is your septal side, right? So just, just a reminder that has nothing to do with the TE, but kind of a reminder for all of our friends here that they are starting their cardiology fellowships. The RV is the one that is essentially defining the septum. So this is going to be anything that is attached into within the RV insertion is going to be the septum. Inferior septum closer to the probe, anterior septum. And the next is going to be anterior, anterolateral, interolateral, inferior, right? So pretty easy to find if you start from the RV and you can work your way around basically, right? And then if you go a little bit further, you're going to see the more apical views, right? And this is what you are supposed to be seeing here. That's a completely normal short axis view. You can see your papillary muscles there and normal function of the heart, normal size. Moving along, cutting short on time actually. 5-chamber view. You basically hug the wall of you hug the stomach and you keep advancing until you see the complete apex, and then you fully undeflex, and then you're essentially creating a 5-chamber view, right? That looks like the reverse 5-chamber from the transthoracic. That's a really good view if you are looking for to do Doppler evaluation of the aorta. It's also a really good view if you have a mechanical aortic valve and you couldn't see anything on your mid-esophageals. You may be able to see much better in the deep transgastric. It's a tough view to get. You have to practice on this view. But look here, what I was trying to say. Here is your probe, right? And you can imagine that you have a really good angulation, actually. Very good angulation. A lot of people think that it is true that with the transthoracic, it's better suited to evaluate for the gradients, right? But if you have a tough, a really big patient, or for whatever reason you cannot get good images, and deep transgastric can actually give you an excellent Doppler evaluation of the aorta. And the one thing that I will mention, you may need to, in order to optimize your angulation of the aorta with the aortic valve, you may need to use the left or the right, do a little bit of, with the small wheel, to do a little bit of left or right turn in order to optimize the beam, right? And this is a 5-chamber view. Obviously this is not a normal patient. I don't know if you guys cannot, we're cutting short on time, so I'm gonna just speak a little bit faster. So you see that it's very highly calcified valve here, right? This is not a normal aortic valve. So there is a little bit of effusion there also. Anyway, so this is your LA, your anterior mitral leaflet, posterior mitral leaflet, and this is the main structure that you're looking for. And then we did Doppler evaluation, and you can see that you are proving severe aortic stenosis. We already know about that actually. We were just doing it to further evaluate the anatomy actually before the surgery. And we actually got a 5.2 meters per second actually, which is pretty high. The transthoracic for the, for what is worth, they got 5 meters per second. Critical aortic stenosis. Anyways, moving along, I kind of already showed that one. From your from your short axis, you can change the angle to the 19 degrees and basically show a 2-chamber view, which is a good view to evaluate for the function of the LV. You see it right here. Again, you already showed that actually on the previous biplane image. And then from there, you can actually go a little bit, increase your ankle to around 113 degrees, maybe turn your probe a little bit to the right, and then you essentially get the transgastric long axis view. Again, kind of similar view of your other long axis view, right? This is a view that you can also do some mitral Dopplers here. But you know what I want to show you, look at, in contrast to the previous image that I showed you, you see that the angulation is not exactly parallel, right? The other one, the angulation was somewhat like that, whereas the angulation here is not exactly parallel. So you can get some gradients, but you know, they are not that great actually. An important view is the transgastric RV inflow view. This is a very important view. You guys should get familiar with this view. Essentially what you are doing is basically from your 90 degrees LV view, you basically turn to the right. You may need to go a little bit higher on your angle, maybe around 100 degrees. You may need to go a touch further in, and you turn around until you start seeing your tricuspid valve. And this is a great view that you're gonna very nicely see and very confidently say that you're gonna be seeing the anterior tricuspid leaflet and the posterior leaflet. This is I'm very confident in this view that you can actually see anterior and posterior, right? And you can, if you get a really good view, you can actually do a 3D of the tricuspid here also, right? And this is a nice transgastric view, again, anterior and posterior. Right here is going to be the pulmonic valve is not seen that well here. This is the array and this is the RV obviously, right? And this is going to be the RVO2 here. Now you are almost done with your study. What you do, you got all of your images. What you do, you kind of turn to the left until you find the short axis of the aorta, right? And then once, what I usually do, so I kind of like optimize the flow of my procedures. I find the short axis of the aorta, and then I do a biplane, so I look at the same time the long axis of the aorta. And then you usually want you increase how many beats acquisition you have, and you start coming out. All right. You may need to flex a little bit and keep your in order to optimize your view. And this is what you are seeing here, right? You're on this view, and basically you start from here and you keep coming up, and keep looking like you have to make sure that you are seeing like a circle of the aorta there. Now remember, in older people, especially if there is tortuous aorta, that's not going to be that easy. You don't just come out. You may need to come out, and then you may need to readjust while you're coming up. Always you want to be looking at the aorta, at the short axis, and make sure that this is just a circle. And then you, on your biplane, you're going to be seeing the long axis here essentially, right? So same thing, you just change your angle. And that's a classic view how I do it usually. So I'm having my short axis here, and I do the biplane, I'm looking at this one here, right? And remember, you as a fellow, while you're coming out, make sure that you are looking this thing and it's a circle. If it's not, then you may need to adjust a little bit, because that meant that there is a little bit of tortuosity in your aorta. And then finally, while you're coming up, then you're going to start seeing, instead of having that circle that I talked about, you're going to start seeing that, you know, that circle starts becoming elongated, and you may even see the origin of the left subclavian. At this point, I take out the biplane, and what you want to do is basically turn a little bit to the right. You may need to flex a little bit more and optimize, and you basically open up the arch, which is going to be right here. And then what you want to be seeing is this one here. So you're seeing part of the arch here. You want to see if there is atheroma. You want to see if there is an extension of the dissection and those kind of things. All right. And we're cutting short on time, actually. So I need to optimize. So very quickly, a couple of questions. I'm sorry that you are going a little bit over time. We're going to eat into the diastology lecture, I guess. Question number one, what is the best view to evaluate the aortic valve gradients on TE? Anyone, guys?
Deep transgastric?
Yeah, so the correct answer is, the correct answer is going to be your deep transgastric 5-chamber view is probably the best one. You know, all of them you can see the aorta, but this one is the one that has the best beam angulation. As you know, you want to have be parallel to the flow, right? Question number two, according to the ASCT guidelines, which of the following is considered an absolute contraindication? Is it varices? Is it strictures? Is it the recent GI bleed? Is it low platelets, or is it history of liver cirrhosis? By the way, none of them sounds any appetizing for a T, by the way, but which of them is the absolute contraindication?
Stricture.
The stricture, very good. The stricture. So if you are suspecting stricture, you definitely want to get GI involved and, you know, maybe do an upper endoscopy prior to doing anything, basically. All right, very good, guys. Any brief questions before I proceed to diastology? I'm sorry that we cut down all on the time. It was a long presentation.
No problem, Dr. Georgios. Thank you for an excellent talk. I have a few questions, but in the interest of time, I'm just going to ask you two questions, which I feel we might have not covered in the talk. One is TEE feasible in patients with large multinodular goiter?
Come again?
Is TEE feasible in patients with a large multinodular goiter?
It should be feasible. I've never had an issue with goiter. I mean, you know, obviously the concern whether it's compressing, right? If you are really concerned about that, you may want to get an imaging to see if there is severe compression of the esophagus. But I've never had an issue with that, actually. I've never had an issue with that. You know, if you have question, anytime you want to have a question on that, you may want to get an axial imaging like a CT in advance and see if there is any significant, you know, compression. But I never had the situation that, you know, that much of a goiter was a problem of compressing the esophagus, basically. And I guess that's what this is. Your concern, I guess, right?
Yes. And
okay.
Second question is, could you describe your checkpoints for TEE when called to the OR post-surgical aortic valve replacement and mitral valve replacement?
Come again?
Could you describe your checkpoints for a TEE when called to the OR post-surgical aortic valve replacement and post-mitral valve replacement?
So, you know, obviously we generally, this is done actually from our anesthesiology team here, so I don't routinely do it. If I had to, you know, some important things that you need to, but in case that, you know, you are called and, you know, some important things you need to consider, obviously, it's going to be the function of the valves, right? So you want to make sure that the valve is functioning well. So you're going to do a detailed evaluation of both valves, and, you know, obviously with color and everything. The other thing that you definitely want to do is, you know, if you have any concerns for intraprocedural MI or anything like that, you're probably going to need to go to get a good transgastric and make sure that there is any, you know, new wall motion abnormalities or anything like that, especially in cases that they did a concomitant bypass surgery. Obviously, you want to make sure that there is no pericardial effusion, you know, that could be related to the procedure. You know, frankly and honest here, we don't routinely do the transesophageals in the OR, so I don't know if there is any further detailed things that you need to focus in this regard.
The other questions, Dr. Georgios, I'll email it to you and then we'll upload the answers on the Iowa ACC website. Whenever you're ready, we can get started with the diastolic dysfunction talk.
Okay, yeah, I think we're gonna start because you're already cutting time on it. So right now it's 10:05. All right. So. All right. So Jay, are you guys able to see the diastolic function?
Yes.
All right. Very good, guys. So we're going to be changing gears, going to diastolic function evaluation. Completely different than the other one. The other one was a very practical type of presentation. This is a very focus on myocardial mechanics and physiology, actually. So on diastolic function, the basics. My goal with this presentation is and you know, that's actually very relevant to the echo board exam. You really need to understand the cardiac physiology and mechanics if you're going to understand physiology. And in the boards, at least when I took it 5-6 years ago, they did have a lot of questions that the basis was more physiology related than echo related. And the rationale behind that, I 100% agree. If you don't understand the physiology, you're never going to understand the Doppler findings without understanding the physiology. Of course, the main document I used for my presentation is the ACC guidelines. They came out in 2016. That is like some focus update in 2019. It wasn't just an up, it was kind of like some summary in 2019 that you guys probably need to see also. People usually ask me what's a good book to read. I actually like especially for the diastolic function, I liked the echo manual from the Mayo Clinic team there, JO. But I'm pretty sure that multiple books would be great in that regard. Now, Let's move along. Normal diastolic function. Normal diastolic function essentially allows filling of the ventricles at rest and exercise. Remember that one, very important. Adequate diastolic filling, of course, ensures normal stroke volume. And remember that your LV filling consists of a series of hemodynamics events that you're going to describe. So what are those events? Initial diastolic event is going to be your myocardial relaxation, that, as you know, is an active energy independent process. That's why when you're having ischemia, you're going to have diastolic dysfunction as an early finding of ischemia. I'm sure you know the ischemia cascade. Then what happens is that the LV pressure becomes less than the LA pressure, and that makes the mitral valve to open, and you have the rapid early diastolic filling. And in a normal patient, the predominant determinant of that early diastolic filling is going to be two things: the elastic recoil and the normal relaxation of the LV. The LA pressure is less important. That's big thing here, right? Finally, with this event, about 80% of the LV filling is going to happen there, all right? Now, moving on, the LV pressure increases, momentarily may exceed the LA pressure. That would be in a normal person, right? And then you have something called diastasis, that basically you have the loss of the positive driving force and you don't have much of inflow. Subsequently, you have your atrial contraction and you have your positive transmittal gradient changing again and creating again flow through that. And this usually accounts about 15 to 20% in a normal patient again. So this is a very important slide. What is the determinants of diastolic function? Kind of mentioned them before: the elastic recoil, the rate of the myocardial relaxation, that active process that we talked about. Then you have the chamber compliance and the LA pressures. So those two here are the normal ones, and then the chamber compliance is that something that could be an issue once you start having, you know, increased stiffness of the heart. And then the LA pressure is the one that's going to be a problem. You start having, you know, increased filling pressures, right? So put them in your head, because we're gonna keep coming back into those four and which one is changing in each case. Some general consideration, that's an important thing also. Before you even dive into your echo, you need to have some clinical data. Essentially, you really need to know the vital signs: blood pressure, heart rate. You need to know the underlying rhythm, extremely important. You need to know about the presence and severity of mitral disease. And you also need to know if there is some presence, known CND and those kind of things. Because, you know, if you already have known structural heart disease, then, you know, you're going to start thinking your diastology in a different way. Now, moving along to the meat of the discussion, of course, the echo evaluation. Those are all, as you can see here, those are all things that you're going to discuss and you need to know about. But the ones obviously with black is the most important ones as defined by the ACC guidelines. And starting is the tuned echo findings, the LVF and the LA size. Number two is going to be your mitral inflow velocities. Now, then you have the Valsalva maneuver, which, you know, we still do, but, you know, it's kind of, you know, falling a little bit of favor out of how important it is. Extremely important, your mitral annulus velocities, moving along to your TR velocities and estimation of the PSP. And then finally, you have your pulmonary vein flow velocities, again, falling out of favors because unfortunately, you don't get great pulmonary flow velocities with transthoracic. You know, in the literature, you're going to see like 60 to 70% you should have adequate. I'm not sure if that's the case, though, to be honest. You know, a good quality, I don't think that I see a good quality pulmonary flow velocities in 60% of the cases that I see. All right, moving along. Mitral inflow, as I said, this is one of the most important things that you need to be well aware of and that you really need to understand the physiology of. What do you measure? You measure the following. You measure the peak E velocity, you measure the A velocity, and then you measure the E to A ratio. You're going to see how you evaluate that. You also need to measure the deceleration time. I'm not sure if you guys are routinely doing it in your lab, but I can guarantee you that you're going to be asked in the board exams. They really like the deceleration time. And decelerate, and what is that? Is basically is the interval from the peak of the velocity to its extrapolation to baseline. And what you need to remember, the normal deceleration time is anywhere between 140 to 240 milliseconds, right? And now, why do you need to know about deceleration time? Well, you know, if you have a relaxation abnormality, what's going to happen? You are deep, like the classic grade 1 as we think of it. The DT is going to be prolonged. And why is it going to be prolonged? because it takes longer time for the LA and the LV pressures to equilibrate, right? We just said you have relaxation abnormalities, so it takes more time to equilibrate. Makes sense. Now, here when it gets tricky, the DT gets shortened if there is rapid filling due to vigorous LV relaxation or last recoil. Remember when I told you those 4 things that affect the diastolic function? So this is the good side of the deceleration time. It's short because everything are working better than great, right? However, then there is a problem. The DT may also shorten if there is a decrease in the LV compliance or marked increase on the LA pressures. Remember those 4 things that I said? I'm gonna keep coming back at those 4. So the first 2, great. The last 2, not as great. So so having a short deceleration time may be good or bad. That's the bottom line out of it, right? Now, moving along, mitral flow velocities. There is something else also that you need to know. And again, we don't routinely do it in our labs, but we probably need to be aware of it for the exam. And it might be useful in equivocal cases. It's something called the isovolemic relaxation time, which is essentially the interval from the aortic valve closure to the mitral valve opening. I'm going to show you exactly some nice images afterward. And if you wanted to remember one thing about that, it actually usually parallels the deceleration time, which is essentially being prolonged with abnormal relaxation and shorter with the rapid relaxation or increasing filling pressure. Same story, right? And then there's something of the A duration, which is basically the duration of the mitral flow with the atrial contraction. And it's actually useful for estimating the LV and diastolic pressures. Why? Because it actually gets shortened with higher LV in DP. I don't think that you're going to be asked on that one. It's kind of falling out of favor. Now, this is an important diagram. Let's kind of focus. I actually got it from the Echo Manual, the JO book. And that's why it's actually reversed with the LA and the RA, by the way. It's the Mayo Clinic orientation. Some important things, where do you put your, it's a PW, you put it at the tip of the leaflets, all right? Remember when you are doing a PW for mitral regurgitation, the continuity equation, you are going to put it at the annulus here, right? And if you are doing it to get gradients, you are going to do a CW. So PW for diastology at the tip of the leaflets, PW for your continuity equation when you are doing a MR evaluation, and then CW if you are doing a gradient evaluation, right? So then if you do it right, you're going to get something like that, your ENA. And this is your, what I said before, this is a very important, you should be able to measure it very easily, deceleration time, peak, extrapolation to baseline. This is the E2A. This is the A in duration, right? Pretty straightforward. And then what you need to have is, if you keep a little bit of the aorta into your view, right? You kind of get the gradient of the Doppler signs of the aortic valve. It finishes here. Then you have your mitral inflow here. And this is exactly where your IVRT is. This one is not as easy to measure sometimes, to be honest. All the rest are pretty easy to measure. Now, how are the mitral flow velocities in diastolic dysfunction?
Dr. Georgios,
yes.
Sorry to interrupt. We can't see your mouse if you're using that.
Oh, again. Yeah, sorry.
Yeah, now we can.
So there you are. The deceleration time right here, sorry. E at A duration here, and IVRT here. Yeah, thank you, Jay, for reminding me that I used the other side of the computer. That's why. All right. And as I was saying here, again, where you do your Doppler evaluation, this is, you put your PW at the tip of the leaflets. If you are doing diastology, you put it here for the at the annulus for your continuity equation for mitral regurgitation. And then you do a CW, which is basically essentially getting the highest velocities for gradient evaluation through the mitral valve. All right, sure you know that, but kind of reminding the more junior fellows. Mitral flow velocities in diastolic dysfunction. So getting to more interesting stuff. If you have impaired relaxation, you are going to have the, so if you have impaired relaxation with mild to moderate increase in the filling pressures, this is where it gets a little bit tricky, right? If you have just impaired relaxation, you're going to start having that reversal of the E to A. So E is going to be lower than the A. When it gets tricky is when you're having this a little bit of mild to moderate increase in the filling pressures, you're going to have opposing effects. On the one side, you have the myocardial relaxation. And then on the other side, you're going to have the increased filling pressure on the mitral velocities. And because you're going to have these opposing effects, instead of just having that reversal of E to A, which is pretty easy to see, those opposing effects on the E velocity are going to get you to a point that it's going to kind of look like a normal filling pattern. And that's why we call it the pseudonormal pattern. And this is what kind of shows what I'm trying to say. This is normal, right? And then you start having, with the relaxation abnormality, you start having increasing the E velocity, right? You expect that because you have relaxation abnormality. And then you get to a point that you have this classic grade 1 type of pattern, as we used to call it, right? But then you start
Dr.
having
Can't
increase.
see the cursor.
Oh, again, sorry. Again. So as we said, normal, starting to have your relaxation abnormality here. But then what happens is that you start having increasing the LA pressures, right? So your E velocity increase, not because you are having more vigorous contraction of the LV and hypernormal, but because it's the LA pressures that are more. And then you come to this point and you see those two are kind of similar between the two. And at this point, if you're just seeing the mitral inflows, you don't really know, is that a grade 1, is it a normal diastolic function, or is it pseudo-normal? And that's kind of part of what you're going to discuss here. Now, what they used to do a lot in the past, and kind of falling a little bit out of favor. We still do it, by the way, don't get me wrong, but it's kind of falling out of favors from the guidelines. Is you do the Valsalva maneuver, as you know, is the forceful expiration against a closed glottis. What it does basically at the phase 2 specifically of the Valsalva, LV preload is the LV preload is reduced. And essentially, if you have someone which is normal feeling pressures, so here is the trick here. The Valsalva maneuver is going to decrease both the E and A velocities, right? Both are going to decrease, and then DT is going to lengthen, right? Because you decrease the feeling pressures. Now, in patients that have already increased feeling pressures, what's going to happen? You're going to have a decrease in the E velocity and lengthening of deceleration time, but you're actually going to have an increase in the A velocity. And if everything sounds a little bit complicated to you, a way to kind of remember in your head, basically a patient with a grade 2 diastolic dysfunction, if you do a correctly done Valsalva maneuver, is going to change it to a grade 1 type of image, considering your mitral inflow velocities. And that's again a nice pictures from the echo manual, and which is essentially showing here that here is your ENA, and then you do your Valsalva and you have this reversal of what you were saying basically, right? And then what that tells you, this is essentially a grade 2. This is not a normal diastolic function that you are looking here. Now, the other thing, another clue is that the E velocity was pretty high here. So I was already suspecting that it's unlikely that, you have an E velocity of 1 meter per second, and that was, it's not unheard of, but it's more or less likely, right? Now, moving along, another important thing, tissue Doppler mitral annulus velocities, right? In order to understand that, you have to remember your myocardial mechanics. Remember that the contraction occurs in longitudinal, radial, and circumferential and rotational planes. I'm sure whoever is going to do the strain lecture is going to talk much more in detail, and that's not my purpose here. What I want to tell you is that what you are really interested when you are doing your E velocities, you are basically interested in the recording the longitudinal motion of the heart. And essentially what you are really interested in is that the longitudinal motion of the mitral annulus has been shown to reflect the rate of myocardial relaxation. That is very important, right? That's the whole purpose, that's the whole idea behind everything that you are doing. And this can be easily be measured, and how you do it. And that's, again, I think that's a question that can be done. How do you do it? It's essentially a PW technique, right? And you're essentially measuring the, because with PW, you can measure velocities as a specific, at a specific area, right? And what you are essentially doing, you're basically excluding, you're changing your filters, you're excluding the higher velocities, that is the blood, and you're just measuring the tissue velocities basically, right? How do you do it? You do it at the apical 4, and you put your PW Doppler sampling at 2 to 5 millimeters over the medial or the lateral annulus, or usually both. At least in some labs do one of the two, we actually do both. And then once you do it, you're going to get 3 distinct velocities, the S velocity systolic, then you're going to have the early diastolic, the E prime as you call it, and then the late diastolic, which is the A prime. What is determining the E prime? The essentially good things, right? The active relaxation and the restoring forces. Those are the main things that they are evaluating. And then you have obviously the lengthening load, which is essentially your preload that really changes when you exercise, right? Now, what happens is that in normal subjects, your E prime is going to increase as the transmitoral gradient increases with exertion or increased preload, which essentially is saying that when this changes, that's going to change, right? Now, what happened though is that in patients with impaired relaxation, the E prime is reduced at baseline, and then it may increase a little bit with the exercise, but it's not going to be an increase good enough, right? And that's actually, this idea behind that is actually the base of the diastolic stress test. I'm not going to talk much about the diastolic stress test because we don't, in the interest of time, but that's kind of the idea behind that, right? Now, decreasing the E velocity is essentially the one of the earliest markers of diastolic dysfunction, and you can take it for sure that if you have diastolic dysfunction, that's going to be low and it's going to remain low. Now remember that the E prime decreases with aging, especially, you know, and the number that we say that usually after 60 years of old, you may have some decrease in the mitral inflow velocity. And, you know, it gets a little bit tricky here. I hope that they're not going to ask you. We call that a normal aging pattern, but, you know, it's actually, there is some, it's not exactly a normal heart. It's a normal pattern, I guess, for that age, but, you know, the question whether it's completely normal and the line between when it starts going to cause you problems or not is not very well defined, I guess. That's what I'm trying to say. But, you know, you expect to see it. We call it normal for the age, but I'm not sure how normal it is, if you see what I'm trying to say, basically. The ratio between, now and then another extremely important thing is that the ratio between E and E prime correlates very well with the LV filling pressures, right? Why is that the case? Well, you know, you have here on the E, we said that what are the things that can affect it, right? And I already saw all those 4 things that could be good or bad. And then the E prime is primarily by good things, right? With your as I show here, with your active relaxation and restoration forces. So by getting the ratio between the two, you're trying to get out of the equation base. You're trying to find what is the number that is really showing that the bad things are really causing the problem, which are essentially the increased LA pressures and the decreased compliance of the LV, right? So I want you guys to understand what is the concept behind getting a ratio of that, right? And, you know, if you think of that, the higher the E to E prime is, the worse things are, right? That makes sense. Now, a normal E velocity for its difference between the lateral and the medial annulus. The reason that because the medial annulus is on the cross of the heart, so it's a little bit, you know, restricted motion based on that. So it's 15 and 10. So 15 for the lateral and 10. That would be the completely normal, right? Moving along, and that's your classic pattern that, you know, at the initial time before the new diastolic guidelines, that was kind of your a real guideline of how to define diastology. So you have this and this, and you would, the way that you differentiate between the pseudo-normal is basically through the E prime, right? Because in the normal person, you have clearly the a normal E prime, whereas in the pseudo-normal, you have a low E prime. You know, with the newer guidelines, you need a little bit more than just that. But, you know, I think the concept still counts, basically, that, you know, if you have good measurements and good quality measurements, you cannot have a pseudo-normal pattern with a normal E prime, basically, right? Moving along, pulmonary vein flow velocities, right? As I said, they kind of fall a little bit out of favor. The main reason for that is that, you know, unfortunately, a lot of times you cannot grade pulmonary vein flows, especially with transthoracic. Actually, with TE that you mentioned before, you can actually get the really good ones. Anyways, what you are supposed to see is there is systolic flow, and then there is diastolic flow. And I don't know if you've ever seen, there is actually systolic flow. I've seen it a couple of times on TEs. You can see actually in distinct S1, which is actually the forward flow in the early systole, which is related to the atrial relaxation. And then you see in distinct, you see in distinct CS2, which essentially occurs in mid to late systole and is actually produced by the increase in the pulmonary venous pressures that comes from the RV, basically, right? Now, during diastole, what happens, there is a forward flow velocity that basically essentially occurs after the mitral valve open, right? So everything basically plays how are the LA pressures are affected, and any time that you have a decrease in the LA pressure, you're going to have like a spike. So it's going to be the systolic and the diastolic. And then finally, with the atrial contraction, basically you have that increase in the atrial pressure, and then you have something called the A reversal, right? And this is what you are supposed to see here. That's the systolic, that's the diastolic. And then you're going to have you always use the EKG as your friend, by the way. So you have the P wave, and then you're going to see your A reversal here. And you can actually measure the duration of the reversal. Now, how is that going to be helpful? The what's showing here basically is basically the pulmonary veins in an abnormal patient, basically in a pretty high LA pressures, right? And going from up, you can, here is the mitral inflow here. So you see that you have a high velocity with a short deceleration time. You were to measure it from here to here. This is a short deceleration time, right? And what you see here is that the systolic forward flow is decreased, right? And why is it decreased? Because the LA pressures are high, right? And then you have a predominant diastolic flow, and then the deceleration. So you see it here. So you have a reversal of the SND, and then the deceleration time of the diastolic flow kind of images the deceleration time of the velocity. That's also shortened. And then finally, your PVA is actually small, which is basically indicating the atrial failure. So this is most consistent with a grade 3 diastolic dysfunction. Now, if you want to, and if all these things kind of sound like complicated and you cannot remember it, at the very least, remember that in a normal person, the S should be greater than D. S remain greater than D even with a grade 1. But once you get more advanced diastolic dysfunction, you're going to have this reversal of the S and D. And if the D is greater than S, that's a clear indication of diastolic dysfunction, as long as you have good image quality, by the way. Now, left atrium, that's much easier. Actually, this essentially reflects the burden of the LV diastolic filling. One of the things that I've heard it being called is the HbA1c of diastolic dysfunction, and why they say that is basically it denotes chronicity. It doesn't always tell you what is the current filling pressures, and the reason for that is because if you had a patient with heart failure that is very well diuresed, the filling pressure may come close to normal, but the LA pressure may still be the LA size is going to remain high, right? Now, one thing to remember is that if you have an entirely normal LA volume, it doesn't exclude completely the diastolic dysfunction, but it's going to exclude important diastolic dysfunction, right? And the caveat to that I'm going to tell you, and I've seen that a lot when I'm doing echo and CT correlations. Unfortunately, our sonographers, and that happened in every single hospital that I have worked on, and intuitively they all focus a lot on they focus the whole exam into the LV, right? They do get some atrial images, but they don't do their best to get a great image of the atrium. And then what happened a lot of time, we underestimate the size of the LA. That's unfortunate, but that's what happened a lot of times. Now, this is a picture that I saw in one of old lectures that I saw, and I think it's a good thing to remember what kind of brings into consideration what we said before, right? So this is a normal LA, right? Like a balloon that was never inflated, normal size here. Then, for whatever reason, you have increased pressure, so you're going to have increased size of the LA here, right? Then you diurese the patient, right? And then you come to this situation here that the balloon is deflated, but notice that even if you took the pressure out, the size of the LA or the balloon in this case remains more than what it was at normal. It's never going to come back completely to normal. That's kind of the rationale behind that. All right. Some pitfall that you need to remember. I already told you that, unfortunately, a lot of times we undermeasure, and I've seen it when you're doing MRIs or CTs, you're actually going to see that even though there is good correlation, don't get me wrong, there is good correlation, it's a little bit underestimated. Other things that, the LA size can be a little bit of misleading if you have atrial fibrillation or flutter, right? You know very well that people with AFib flutter, they're going to have huge atria, and that's not exactly going towards the pressures or the diastolic functions because of the AFib, right? Other things is significant mitral valve disease. So if you have a MES, you're going to have a big LA, and that doesn't necessarily has to do with the diastolic function. High flow states, and of course with cardiac transplantation, you can have a large atrium with that has nothing to do with diastology, right? Moving along, Pulmonary arterial pressures, again, one of the essential parts of the diastolic function evaluation. How do you do that? By getting a good TR velocity. As you guys know, you have to get the TR velocities in multiple views. And then from the multiple views that you're going to get the highest one, right? Is considered elevated. If it's more than 2.8 meters per second, then you start, you do your 4-base square, you're getting into the 30s basically, right? And of course, if you have inadequate tracing, you can consider actually repeating measurements after contrast or bubble administration. Now, here's my point here, and we do that also with the aortic valve evaluation, right? So if you give contrast and you do the repeat gradients, right? It's not that the contrast is changing the gradients by any stretch, right? That's not the point. It actually makes the Doppler signal more prominent, so it's easier for you to get the signal better, rather than, it's not that it's changing it by any stretch, it's just making it easier for the sonographer. There is more areas that you can get the peak flow there. The signal is more prominent, so it's easier to get basically, right? Now, one thing to remember, and it's important, when we are doing all those things and we are talking about diastolic dysfunction, the use of the TR velocity in diastolic dysfunction is assuming that there is no problem with the pulmonary vascular disease, or so essentially you don't think that there is primary pulmonary hypertension, because obviously you can have a completely normal diastology, and if you have primary pulmonary hypertension, your TR velocity is going to be high, right? So that's an assumption that you're making, and you don't really know in advance unless you know clinically what is going on. Now that you have our basic ins, let's go to how are going to be the all of those parameters in normal and abnormal individuals. So remember, in order to learn abnormal, you need to learn normal, right? So what is going to be normal diastolic filling? Let's say as we said, most filling is completed during early diastole, only a small contribution of the atrial contraction, right? The E2A is usually 1.5 or even higher. Deceleration time 160 to 240. The E-septal is going to be at least 10. And the E2E ratio is going to be less than 8, right? As we said with the Valsalva maneuver, both E and A velocity are going to decrease, the DT is going to lengthen, and the E2E ratio is going to remain about the same. Another thing to remember is that the lateral annulus is always higher than the septal annulus, right? And we said why? Because the septal is on the crux of the heart that kind of restricts the motion, right? And just a question to make sure that you guys are listening to me. What is the classic condition? I'm not going to talk too much about it, but what is the classic condition that you have a reversal of the lateral and the medial annulus? Anyone?
Constrictive pericarditis.
Constriction, right? Very good. And why is that? Because obviously you have the all those calcification of the pericardium limits the motion of the lateral annulus, right? Anyways, the constriction and the pericardial disease, I'm sure, is another lecture in this series. The in prime, as we said, increases with an increasing transmedial gradient. Remember that nice schematic that I showed you from the guidelines, actually. So, however, the E2E is going to remain similar, right? Essentially saying that the filling pressures are going to remain normal at rest and with exercise, usually less than 10 or actually even usually less than 8. When you have impaired myocardial relaxation, the mitral E velocity is decreased and the A velocity is increased. So essentially you're going to have that classic image that you used to have, the reversal of the E and A, very easy to find. The IVRT is going to be prolonged. The same is going to happen. So remember, the DT and the IVRT usually go the same direction. The PV diastole is going to parallel the E velocity, and it's also going to be decreased. Usually the S&D ratio actually stays the same though. So in just relaxation abnormalities, the S is higher than D actually. Duration of the A velocity is usually normal. Now the E prime, so there is some things that already start seeing is that the E prime is going to start getting reduced, right? As we said, E prime, if you are measuring it correct, any degree of diastolic dysfunction is going to be low. You cannot have a normal E prime and diastolic dysfunction as long as you measure it correctly. Remember that one, because unfortunately in real world practice, things are not, people don't read books. Essentially, sometimes you have terrible images and, you cannot take it to the bank that that's the case. And then finally, the diastolic filling pressure is not increased though, right? Because we have impaired myocardial relaxation with normal filling pressure in this case. So the E2A is going to be low. And that's our classic mitral inflow with the reversal of the E2A and the prolongation of the deceleration time, right? And all the IVRT, as I said, is going to be also prolonged. Now, moving along to, that what comes a little bit more tricky and, probably more, a lot of things that could be asked is that pseudo-normalized pattern, which essentially gets its name because the mitral inflow looks the same as the normal pattern. What happened is the E2A ratio is going to be, again, normal, 1.5. The DT is going to be normal. And why is the DT going to be normal? Because you have the two different things that they are affecting in a different way, right? You're going to have the abnormal relaxation, but at the same time, because of the increased filling pressures, both are going the different directions, and you end up looking as if it's normal, which is not. So the best way to identify that is if you are getting a good E prime, and if it's less than 7, then that means that there is something wrong going on, right? There is no way that if you had a normal patient, their E prime should not be less than 7, right? And then the increase, and then usually if that goes with increased filling pressures, the average E to E prime is going to be greater than 15. When I say average, is meaning the average. I use the E is just 1, right? So the average E prime, essentially you get the lateral and the medial, you add them up, divide by 2. That's your average, greater than 15. If you have just 1, if it's from the lateral, it should be greater than 13, and from the medial, greater than 15. Actually, this should be 14, actually. Now, if LV of now, the one trick to remember, that's why it's good to know you are a little bit of clinical information from before. If the LVs of abnormal size or systolic function or increased wall thickness, impaired relaxation is expected, right? So if you actually have this abnormal LV and you are seeing what we call a normal pattern, you should already be suspecting that this is not a normal pattern, it's a pseudo-normal pattern. And then, and essentially this is what this is saying, that the normal E2A is basically suggesting that it's a pseudo-normal pattern. Now, if you were to do a Valsalva maneuver in this case, by decreasing the preload, you're decreasing the filling pressures, and you may be able to unmask the impaired relaxation abnormalities, causing a reversal of the E2 ratio by more than 0.5. And then you're also going to prolong the PVA. But I think the easiest way to remember is essentially this, what is showing here. So you have your ENA, right? And then you do your Valsalva, and that actually kind of reverses that I showed again before to a pseudo-normal pattern, right? Now, the one thing that I wanted to mention here, what is this thing here? You see, we showed the ENA. What is that thing that I'm showing there? Anyone?
L wave.
L wave, right? Good. So once you see an L wave, by the way, abnormal. There is no way that you see an L wave and that's normal. It's, by definition, the filling pressures are high. So that's also a trick there. They may show you just simple as that. And then the question may not be diastolic dysfunction. They may just ask you, what do you think is the filling pressures, and be like, normal, abnormal, or cannot determine, or needing more information and all that stuff, right? Moving along to a very abnormal diastology, which is essentially the restrictive filling. You have increase in the LA pressure, which results in earlier opening of the mitral valve, shortening of the IVRT, and due to all that, you're going to have an increased initial transmittal gradient, which is going to show up as a high E velocity, right? Now, early diastolic filling in a non-compliant LV is going to cause a rapid increase in the diastolic pressures, rapid equalization of the LV and LA pressures, shortening of the DT, right? So again, as I said, remember the IVRT goes with the DT, they are both shortened. So high velocity, shorten IVRT and shorter DT. Now the atrial contraction increases with the LA pressures, but the A velocity and duration are shortened. Because why? Because the LV pressure is increasing even more rapidly, right? Because you have that stiff ventricle there. And essentially what you really need to remember is that in restriction, you're going to have increase E velocity, decrease A velocity, and then the ratio is going to be really high, and essentially it's going to be 2A is going to be more than 2. You're going to have shortened deceleration time, less than 160. and 140 in some, depending on different textbooks. I've seen 140 or 160. I hope that if they're going to give you a number, it's going to be clearly low. And then IVRT of less than 70, right? And then importantly, the E2 ratio, if you really want to remember something, E2A for the restricting feeling like grade 3 and grade 4, E2A ratio is going to be more than 2. All right? And we are still on time. Restrictive feeling pattern, your pulmonary vein flow is essentially going to show what you said before, the reversal of that S and D ratio, and then the atrial contraction, the increase in the LA pressure is going to produce a prolonged PVA. All right, maybe not as important. Now, extremely important here, because the myocardial relaxation is important in this patient. Remember, once you have diastolic dysfunction, the E prime is always reduced. So you are going to have a low E prime velocity, and it's actually usually going to be extremely low, sometimes 5 or even less than that. And then classically, your E to E prime is going to be more than 15, and essentially indicating high feeling pressures, right? Now, in the restrictive feeling pressures, now you would, you are considering right now that you have restrictive feeling pressures, and you're wondering whether it's a grade 3 or a grade 4, right? So you can do the Valsalva maneuver, and by doing it, and especially if they do it the correct way and you measure it the correct way, you may reverse a restrictive feeling pattern to a grade 1 or even a grade 2 pattern, indicating reversibility, right? So if you do the Valsalva in reverse, then it's a grade 3, and that's great, right? Now, remember though that if you do a Valsalva and it does not reverse, that does not mean by definition that is a grade 4 or a non-reversible, because what happened is that one, the one possibility is you didn't do a good Valsalva, or the feeling pressures were that high that even with Valsalva maneuvers, you are not able to reverse it to become a grade 2. So essentially, if you do the Valsalva in reverse, then you can say confidently that it's reversible. But if you do it and it doesn't reverse, you cannot say that it's not reversible, basically. Right? Now, with all this in mind, we go to the famous flow chart that they are on the 2016 guidelines, and you really, really need to have them in your head. Those numbers, it's a must know for the exam. It's actually a must know for everyday clinical practice also, right? So the question here is, how, with all those things said and done, how are you going to evaluate the diastolic function? And the first thing you want to question is the patient, does the patient has a normal heart, right? And does the patient has a normal EF? If the patient has a normal heart and normal EF, then you come to this flow chart here, which is basically going to tell you, is there a diastolic dysfunction? And to decide that, you're going to see 4 things. One, and you really, really put them in your head. I'm sure that you know them, but I cannot stress enough that you need to know this inside out, numbers in your head, like, do them a tattoo in your heart if needed. All right. Average E to E prime more than 14, essentially saying that there is high feeling pressures, a septal velocity of less than 7, or a lateral velocity of less than 10, if you're measuring both in your lab, and we do in our lab, a TR velocity of more than 2.8. Remember that caveat that you said about the primary pulmonary disease that gets confusing. And then the LA volume index of more than 34. And, just one thing that kind of worries me about this 34, if you have an extremely obese patient, they are always going to end up having a normal LA. But anyway, that's beyond the purpose of the discussion. But anyway, for your boats, 34 is the way to remember, right? And then what happens is 2 or more, if you have 3 or more of those positive, then you have diastolic dysfunction. If just 2, then you are stuck and it's indeterminate, and I'll tell you what to do in that case. And if less than 2 of them is positive, then it's a normal diastolic function, and you are done. So in this case, you are done. In this case, what you're recommending is basically, if you have time, you send your sonographer and get repeat images. Maybe go measure again the TR velocity, maybe get a better measurement of your LA volume index, maybe try again the E primes if they are not well performed, right? In addition to that, again, if you are stuck in that indeterminate case, then maybe if you had if you happen to have a good pulmonary vein flow, that may be basically suggesting an abnormal diastolic function, right? So that's, again, kind of, you start with these ones, but then if you're getting stuck in here, you may consider the pulmonary vein. So as I said, it's not that they are useless, but they are, coming a little bit less than on favor. Now, if you decided that you have diastolic dysfunction then, right, then you go ahead on the next table, which is basically the mitral inflow. The next table is going to tell you what type of diastolic dysfunction you have. Now, I will mention that you should go directly to this if you have a patient with a structurally abnormal heart, or if you have a patient with a low EF. Forget about the first, you come directly here. Because if you, let's say you have a patient with an EF of 35%, you know that there is diastolic dysfunction. So you don't care to decide if there is diastolic dysfunction, you care what is the filling pressures, do I need to aggressively diurese this patient, right? So this looks a little bit more complicated, right? So let's break it down. The easiest way to remember is this, the easiest thing to remember is gonna be this part here, right? So you decided that there is diastolic dysfunction, right? You go to your mitral inflow. If the ENA is bad, meaning greater than 2, that means that you have grade 3 diastolic dysfunction or whatever, grade 4, right? So this is bad. So get that out of the way. Then I usually come on this side here. Is your mitral E velocity more of like the ENA that, kind of pseudo-normal type of pattern with a pretty low E velocity, less than 50? Remember, if you know that you have diastolic dysfunction, you really want to have your E velocity to be low, because it's not the high velocity because of vigorous athletic person with exercise and stuff. It's gonna be abnormal. So you want it to be low. And if that's the case, then you have normal filling pressures, and then you already knew that there is diastolic dysfunction, so it's just a grade 1 diastolic dysfunction. Now, if none of the two is the case, then you're stuck in the middle. That gets a little bit more complicated, right? And then you use 3 criteria, kind of similar to the ones that we had before, but you take out one of them. So you use your LA volume, the same, you use your TR velocity, and you use your average E2E, right? You're not using your just single E prime number. You're just using those 3. And then if 2 or more of those are positive, then you have grade 2 diastolic dysfunction. If one or less is positive, then you have your normal diastolic dysfunction. And then the problem becomes, if you only have 2, for whatever reason you couldn't calculate the 3, and you only have 2 and you are stuck between the 2, then you cannot determine the diastolic function. All right, is it clear, guys? It's a little bit of a more complicated diagram, but if you break it down, starting from here, come here, and then in the middle, I think kind of make more sense. Any questions in this diagram? It's a very important diagram, and it's going to be, most of the questions I think is going to be coming from this diagram. Or I guess you can finish up and discuss questions at the end. Moving along, some exceptions. If you have atrial fibrillation, it becomes pretty tricky. Hopefully they're not going to ask you those things, but what happens with atrial fibrillation, obviously your LA is going to be enlarged, right, because of the AFib. And then your TR velocities are going to be all over the place because you're having different cycles. You can still measure and get the average, but that's a problem. And then you can still measure the average E2E, but remember that you are getting an average E2E prime, and it's not great, right? You are assuming that because you average, you are doing the right thing, but I'm not sure how good it is. I mean, people have said that you can try it and it has some correlation, but it's not as great. Some things that you can consider, again, I don't think that you should be asked, but a really high velocity, like talking about an velocity of 1.9, is actually, that remains about high always. So if you're seeing a patient, usually if you have a fib with different cycles, right, you should be seeing the E to be varying like based on the, the regular heart rate, right? But if the E velocity is really high and remains always about the same, that means that there's really high filling pressures basically, right? Next thing is, if you have significant mitral valve disease, then you cannot use your E2E to estimate the LV filling pressures. And when we say that, that includes also moderate or above annular calcification. Not just if you have like a spot of calcium there, but if you have quite extensive calcification, that's a problem. Any mitral stenosis, even mild mitral stenosis, that's a problem. It doesn't count. If you have moderate or above mitral regurgitation, if you have any valve that is prosthetic or repaired or anything like that, then it's a problem. It also doesn't go for LV assist device, LV bundles, pace rhythms. Oh, and I forgot to mention with the transplant hearts is not going also. All right. Another consideration is after cardioversion, what happens is that because you have this stunning of the atrium, that becomes a problem. And what happens is that you want to use the deceleration time, should you be used if you want to get an idea of the diastolic function. The main issue here is because of the, it might be like a little bit of, too much of in detail, but the idea is basically because you have the atrial stunning, the mitral wave is going to be decreased, and that is not reflecting the diastolic function, is more due to the stunning. And then you end up having that E to A ratio that is 2, greater than 2, but doesn't really mean that you have a restrictive pattern. Is just because of the atrial stunning. I think that's the main thing that I want you guys to remember from that, is that right after the cardioversion, you may have this business here of E to A greater than 2, but that doesn't mean that it's related to the diastolic function. It's just the atrial stunning. All right. Moving along, let's go to questions. We still have some time, right? Yes, you have 5 minutes. So restrictive physiology is characterized by the following findings, except. So everything is true except what is wrong here. The mitral flow velocity show increased E velocity. You're going to have decreased A velocity, which is generally going to be much less than the E. You're going to have shortened deceleration time, less than 160. You're going to have increased systolic forward flow velocity in the pulmonary veins. And 5, the E to A ratio is going to be greater than 2. So what is the correct answer, guys? Anyone?
Everyone is saying
4.
4, good. So 4 is the correct answer. Why is that? Because essentially the correct answer, the correct would be the systolic forward flow velocity in pulmonary veins is going to be decreased, right? And why is that? Because of increased LA pressure and decreased LA compliance, right? And as a trick for the exam, even if let's say you didn't remember what was going on with the pulmonary veins, you can always see that this is true, this is true, this is true, this is true, and then okay, that has to be wrong. So sometimes even if you don't know something, if you can exclude other things, that may help you. All right, so this is an easy one, but I really want to get this into your head. Which of the following is not part of the initial pathway for your diastolic function evaluation? That diagram number 1 that I said. Is it the LA size? Is the average E to E ratio? Is it the mitral flow with Valsalva? Is the mitral annulus velocities, or is it the TR velocity? Anyone?
Three.
Sure, 3. So really, again and again, I cannot stress enough, learn your numbers. You should never, don't go for the exam without knowing the numbers there, right? And let's go to a quick question here, a little bit more clinical question. So 65-year-old male, past medical history of coronary artery disease, anterior MI 3 years ago, and is presented to your clinic, and he has tells you that I have decreased exercise tolerance. You do a TT, of course, because you always do a TT, and reveals a normal LV size with a little bit of LVH, moderately decreased function, EF of 35%, and known apical akinesis that you knew from before. Then you have your mitral inflow that is showing that, and for whatever reason in the exam will do that to you, they don't give you any more information. The question is, what is the diastolic function of this patient? Is it normal? Is it grade 1? Is it grade 2? Is it grade 3? Or I need much more data, I need the E prime and all those things. What do you guys think?
4. Grade 3.
Good. So it's 4. Why is it 4? It's 4 because, and again, I didn't give you the numbers, but you can clearly see that the E to A ratio is 2, right? It's greater than 2, not to forget about 2. It's greater than 2. You knew from the beginning that this is not normal because the patient has an OEF. You knew that, and going back to your initial flow here, you know that the F is bad, ENA is greater than 2, structural heart disease, you are done. You don't need, in clinical practice, you're going to have more information. In exam, I think it's a fair question to ask. All right. Some time for questions. Again, if you have a couple of minutes, Jay, if you have a couple of, and I would like, before you come to questions, if you go to the 2019 document, there is kind of a brief update. it gives some specific situations like hypertrophic cardiomyopathy patients and, you know, what you do in arrhythmias and those kind of things and transplants. I didn't have time to mention them, but you guys can look at them. I don't think that you're going to be asking those ones. They get much more complicated. And I don't think that you have adequate data to be confident in answering those questions. But, you know, it's there and you could also read them in your leisure. So any questions?
Thank you very much, Dr. Georges, for an excellent talk. We have quite a few questions, but in the interest of time, I'm just going to go over two. The first one is how to differentiate grade 3 and grade 4 diastolic dysfunction.
So we kind of discussed that here, right? So right here. So we do the Valsalva, right? So what happened is you do the Valsalva, and as long as you really did a good Valsalva and the LV filling pressures are not that high, if you have a reversal that makes it a grade 2 or grade 1 from grade 3, grade 2, then you say that is a grade 3, right? Now the problem is that if you do not have a reversal, that does not mean that's a grade 4. So at that point, you just say it is a restrictive filling. And what happened is that you cannot know from echo where is a 3 or 4 basically. And essentially, if you have, you can always call irreversibility if you only have objective evidence of a persistent restrictive pattern with normal filling pressures. And you may need even, you may even need to do cut hemodynamics in order to prove that actually. So with echo, if you just have a single echo, you can say that is a grade 3 if there is reversibility with the Valsalva. If there is no reversibility, you are just stuck to say it's restrictive and no more answer whether it's 3 or 4. All right?
Thank you very much. I think we are short of time now. So whatever questions are left, I'll email it to you and we'll upload it on the Iowa ACC website.
All right. Excellent,
Thank you
guys.
very much once again.
Thank you. Have a nice continuation there. Bye.
Can you stop sharing your screen, Dr. Georgios?
Yep.
Thank you.
Stop share.
Thank you very much, Georgios. That's an excellent review of the two very difficult topics. Really appreciate your contribution to the fellow education. Going to move on and introduce our next speaker at this time, Dr. Archit Sharma. Dr. Archit Sharma completed his residency in cardiac anesthesia at the University of Nebraska Medical Center and critical care anesthesia fellowship at Mass General in Boston. And since then, he's been here at the University of Iowa as an assistant professor in the Department of Anesthesiology and Critical Care Medicine. He graduated from his MBA from the Henry B. Tippie School of Business in 2019, where he was my classmate. And he's board certified in general anesthesiology, cardiac anesthesia, and critical care medicine, serves as the fellowship director for the Anesthesia Critical Care Fellowship, and is very closely involved with the residency and fellowship teaching programs. And he's been the recipient for multiple teaching awards. He has a passion for echo, both TE as well as transthoracic, and he continues to stay involved with national organizations like the ABA and SCA and conducts workshops with them each year. I'll go ahead and let Dr. Sharma take over, and he's going to be talking to us about artifacts on echo. Over to you.
Thank you, Mahi. Well, first of all, thanks for letting me be a part of this this teaching experience, and I was looking forward to this. Let me try and share my screen, make sure that you guys can actually see the PowerPoint. So here we go. I'm going to go ahead and share my screen. All right, can you guys see this? I'm going to try and make it full screen here. How about that?
You need to swap to present.
So do I need to swap screens or?
Yes.
Yeah, I think
Okay.
screens.
There you go. How about that? Better?
Perfect.
Perfect.
Okay. All right. Great. Now that we got that out of the way, you know, I wanted to offer obviously my first thanks to Dr. Ashwath, who, as my former classmate, was always top of the class and, you know, provided us with inspiration to keep moving forward. Secondly, I would also like to thank another colleague, Dr. Jay Parekh, who's kind of been, you know, running the show and moderating all of this. Jay was really, really instrumental in helping me get a couple of loops for this presentation. So Jay, thank you so much for your help. Just wanted to acknowledge that. I will move this talk along and you know, discuss a few things that are important. You know, I have no particular disclosures, unfortunately. Even though Mahi is my close friend, does not pay me for giving this talk. I don't have any conflicts of interest, and neither is Philips or GE paying me for any of these things. So one thing that I think is important to kind of discuss as we go along discussing artifacts is to know what the meaning of excited to sad ratio is. As I think about how excited and how sad I am on a Saturday morning, I try and think of what is on my agenda. I'm giving a talk on artifacts on Saturday. You can take a guess on whether that makes me excited or sad. I got to do taxes because taxes are coming up. So again, that kind of makes you think how excited or how sad I am about that. I got to deal with a monster who is running around in this house. And as an honest disclosure, well, for people who were there in the last talk we did, the previous year, that door opened about 30 or 40 minutes into the presentation, and the monster walked in. So if that happens again, I'm going to try and be, very honest with my disclosure. My wife has a cadaver session today, so I've got plans in place, but things might change. And then the last thing is I am an anesthesiologist by background. I work in the heart room, I work in the cardiac ICU, and I am giving a talk to a room full of cardiology experts. Yay. So that gets me excited as well. This is the said monster. I've put him into a good spot today. Hopefully his Nintendo Switch and the TV will keep him busy. But also he could come here and do all kinds of funny stuff. So what are our objectives for this morning? We're going to try and increase our excited to sad ratio. We're going to make sure that the monster kind of stays out of our business. I hope that his Nintendo Switch has enough juice so that it lasts all of this time. And then my sincere hope would be that I don't go to sleep. I don't let you go to sleep. And we'll deal with taxes when that time comes. So moving on, we got to try and get a better understanding of why artifacts exist in ultrasonography. We'll try and develop a better understanding of what kind of series of assumptions do we make, and then also the machine makes. What is going on with that machine that creates these things that we see on our screen, which either don't belong there, or well, they kind of belong there, but they're at a different spot. That's not where we expected them to be. So we're trying to get an understanding of the concepts behind the development of artifacts. Obviously, no echo talk or no cardiology talk would be complete without looking at a few echocardiographic loops, a few pictures to be able to recognize these artifacts, and then maybe discuss a few strategies on how to well identify them and then try to get rid of them or image more accurately. So, the word artifact kind of comes from two Latin words. One's art, which is skill, and then factum, which means to make. So, when we kind of use our skill to make up things that don't really exist, or they exist in another form, in another dimension, and we're imaging it in a different view, that is what an artifact is. As technology has advanced, as we are looking at better and better ultrasonography technology, better machines, more ways of imaging, it's also kind of created this problem because the more defined that we've gotten, the better our resolution has been. It's kind of created these things that we now have to deal with as we start imaging these patients. So can anyone tell me any classification on artifacts? Does anyone have any insight? I'm sorry, I don't have the chat screen. So Jay, if something shows up in the chat, just let me know.
Sure.
All right, I'll move forward. Here's my classification for artifacts. They're easy, they're difficult, or for some people, they're kind of just impossible to deal with. Very similar to dating. For some people it's easy, some people it's difficult, and then other people it's almost impossible. So you kind of have to deal with it in a way that works for you. There are certain things that you're going to be able to do to minimize artifacts. It's kind of hard to almost get rid of them because they are, a physical property of ultrasound waves. But as long as you know that whatever you're imaging could have an error, and it's not absolute, I think most of the times that will keep you out of trouble and help you dodge these problems. When I was a fellow, one of my professors used to say, which I think is a very, very true statement. It applies to essentially my entire practice, whether it is the TE in the cardiac operating room or transthoracic in the ICU. She used to say, you can't really convince me of anything until you can show me in two different views. So, I guess the deeper meaning behind that was just looking at one picture or you're looking at one loop should not drive you to a diagnosis. You should be able to verify it in more than one ways, whether you do it in two different views or you do it with different depths or changing your focus. Either way, you should be able to demonstrate a true object in more than one dimension. So, what are artifacts? They are errors, like we discussed. They are errors in imaging. They're not real. They're either there is an inaccuracy in their size, their shape, their brightness, their location. Sometimes, things exist in one particular chamber and we're looking at it in another chamber. Essentially, what happens is that we make a series of assumptions and the ultrasound machine makes a series of assumptions. And when all of those things align, just like in a Swiss cheese model, all of those things line up right next to each other, then an artifact or an object is created in your visual field, which is aberrant, which doesn't really exist. Like I said, it is a physical property of the ultrasound wave, so it occurs when an ultrasound beam interacts with the different media inside the body. Sometimes it can be an equipment malfunction. We'll kind of talk about that down the course of this talk. Sometimes you are just looking at a probe where the piezoelectric crystals are broken, or you're looking at an image when there is some external interference that is going on. Electrocautery is a very easy and common example of that in the operating room, at least. You can have these artifacts show up. Sometimes it's operator error, but usually that is the last cause, and probably the most easy to remedy. Most of the times it's going to be, like I said, an interaction between the ultrasound waves and the different media inside the body. You've got bone, you've got lungs, you've got myocardium. All these tissues interact with ultrasound in different ways and create these artifacts. Basic components of an ultrasound system consist of a pulsar, a transducer, a receiver, and a display. A transducer and receiver pretty much essentially end up being the same in our practice, because the same probe that we use to transduce is going to be the one listening and receiving those ultrasound signals back. The pulsar is the one that actually controls the electrical signals sent to the transducer. So your pulse repetition frequency, your amplitude, and steering, all of those will be decided by the pulsar. I'm sure you guys already are aware of that. What does an ultrasound really know? An ultrasound knows the strength of the signal that it is sending out. It also knows the strength of that signal coming back to it, and that's how it kind of gives a certain degree of density to your to the actual picture that it frames for you. You probably have heard terminology such as echo dense and echo lucent. That kind of depends on the strength of the ultrasound signal that is being received by the ultrasound receiver. It also knows the direction that the beam was sent in. That's part of that algorithm that it uses to calculate and then project that final image on your screen. It knows I sent it this way, now I'm receiving it from a particular direction. This is where that object is based off of this direction that I received this ultrasound signal from. And then it knows arrival time. It knows how long it took after that frequency was sent, that sound wave was sent, and how long it took for that sound wave to come back to the receiver. Why is that important? It's important because that is how an ultrasound decides depth. That is how it knows that, well, it took me X amount of milliseconds for this sound wave to come back to me. The object of interest is at Y depth. If it takes longer, then it projects it at a higher distance, and you will see that you'll see a deeper image. You'll have to increase your depth to be able to image that area of, or that object of interest. So it knows the strength, it knows the time that it takes for the ultrasound beam to come back, and then it knows the direction that it sends it in. What kind of assumptions does it make? Well, one of the assumptions it makes is that the amplitude is constant. Obviously it is constant for that short term that it's sending that beam out in, but things change from that point onwards, and we will talk about that. It also assumes that the direction is a straight line. The ultrasound thinks, well, here are the crystals at the probe. I'm sending this beam out, and then it's going to come back to me at that particular point. It assumes a constant velocity of 15 and 40. That's the speed of sound. From as far as the ultrasound machine is concerned, it's a physical principle. It says, well, yep, that's what it went out with. That's what it's going to come back with. And then it only assumes that there is a single trip that the beam makes. It goes down, hits the object of interest, and comes right back. All that is great, except for the fact that there is interaction that happens at the ultrasound tissue interface. And you can imagine any kind of interface for that. You can imagine the lungs where, there is going to be a pleural interface, and then there's going to be an actual lung parenchyma interface. You can imagine the heart where there's going to be multiple interfaces, right? The beam has to travel through the chest wall. So skin, subcutaneous tissue, there is some degree of bone that is going to interact with. Obviously, you're trying to shoot through your imaging window. So there is intercostal muscles that it will deal with. Both of the pleura are going to be in between, the visceral and parietal pleura will be there with some pleural fluid. Then you get through the lung and go on to the pericardium, the pericardial fluid, before you actually get to the myocardium. So the sound beam that's been sent by the transducers already interacted with so many different media with different densities and different kind of interactions with the sound wave before it reaches your area of interest. I mean, we haven't even gotten as far as the valve or that tiny vegetation that we're trying to look at. I'm just saying, this is why it is hard to get rid of artifacts, because some of these are going to show up in your visual field. Once the ultrasound beam gets and interacts with any of these media, you're going to see different forms of interaction. It can either get reflected back, which is what is the assumption, that it goes down and comes right back. But there are other things that happen as well at the same time. Some of this ultrasound energy or some of these ultrasound beams are scattered, which means they kind of just go into random directions. They can be refracted, which means they continue in almost the same direction with a change in angle. And then sometimes it can be attenuated, which means that it continues in the same direction, but the amplitude is decreased based off of that media that it interacted with. If you think of a media like air or bone, they pretty much get completely attenuated, and that's why you're not able to visualize the far field once you've interacted with an attenuating media. We assume that sound travels in a straight line, but there are enough examples to see that in the ideal world, if it's a homogeneous medium, if you are just traveling through muscle, for example, then most of the time sound will travel in a straight line. Can you guys see my pointer?
Yes.
Yes. Okay, great. That you'll be able to see that sound is traveling straight. But if it is traveling at a point where it's interacting with two different media, or it comes in contact with, like a fluid pocket, it could be an effusion, it could be, a cyst in the way, that at that point, it can demonstrate that this travel is no longer in a straight line. It could be bending all the way. I mean, this is an exaggeration, but this is most likely what happens. It goes, hits that media, and then changes the direction at which it was initially traveling. We also think that reflections only arise from structures on the beam's main axis, but we got to understand, and as you guys probably already know, that your ultrasound beam kind of isn't just one straight line. You kind of have this old knob that you use, the focus, that kind of tries to focus that beam at a particular area of interest, and then the beam kind of diverges from there. So you no longer are really looking at a straight line. You kind of have a fan of sorts that you're going to look at. Any object that is going to interact with the ultrasound beam at those particular depths is going to create a different kind of image when it gets back to the receiver. We know that sound travels at 1540 meters per second, but like I just described, there are different media that you're going to now travel through. as you go through different media and as sound goes through these different media, it is going to change its speed. And this difference in speed, what it does is it changes the time it takes for the sound wave to go back to the receiver. It's not so much that the receiver cares about the speed, it cares about the time. It cares about the time that it takes for this reflection to get back to the receiver. And hence it is going to show images at different depths for you. We also think that sound just goes back and, front to and fro and doesn't really cause a reflection. This is probably the biggest reason why we have these artifacts, is that sound will go, hit one structure, bounce across the second one, and then come back. The direction of this beam is not from the area of interest. So the ultrasound will look at this and imagine this. So that's the real keyword here, imagine, cause an artifact, to be coming from this direction. And obviously, this is going to take a little longer than what this beam did. So obviously, it is going to be projected at a deeper depth in your eventual image. So, this is kind of like a sum total of why you have artifacts in your ultrasound picture or in your imaging field. It's because of the assumptions that the ultrasound principles are based on. Again, it might not be possible to completely get rid of these artifacts, but what is important is that you realize what you're doing, what particular structures are being imaged. If a sonographer has imaged and sent you, the files to review, for you to be cognizant as you go along imaging these, knowing that there are certain things and certain structures that if they don't make sense, that they probably should be reviewed in another form, in another dimension, and in another view. So we're going to go ahead and look at this picture and then see if someone can identify an artifact. There's a bunch of them, but just food for thought. It might kind of show up in a couple more. So I'm going to give you guys maybe just another 10 seconds to absorb this and look at this, and then we'll kind of move forward. So, there are going to be different ways or different modalities that are going to cause different kind of artifacts. We are going to try and quickly, touch up on all of them. Using spectral Doppler will give an artifact based off the angle of incidence. Aliasing is another thing that most commonly comes up as an artifact. Beam width mirror image artifacts are clap and go answers. I call them clap and go because you get that image on your board exam and you clap and go and you're like, yep, I know the answer, I'm going to move forward. Range ambiguity, most people know that continuous wave Doppler isn't able to specify a particular range from where that is coming from. Color Doppler will show us shadowing. It will give us problems with background noise and sometimes underestimation of flow signals. There are going to be ultrasound-based artifacts such as poor quality, poor penetration, reverberation artifacts, and then things like foreshortening that we're going to go ahead and discuss. Angle of incidence is one of the very basic principles that is taught to cardiologists, to anesthesiologists, and intensivists, is that you're only as good as your image, and the weakness is going to be displayed right up. If you cannot line yourself up with the flow or the velocity that you're going to measure, obviously you're going to introduce error into your assessment. As you guys probably already know, when you are trying to image velocities, you probably want to be at very parallel to them. So 0 degrees is going to be your proposed angle of incidence. Up to 20 degrees, you probably will have about 6% error. The amount of error is going to vary with the cosine of the angle. So, cosine of 0 is 1, cosine of 90 is 0. So at 90 degrees, you're going to have the maximum error in your assessment. Most people try and stay within that 20 degree accepted error bracket. But that is going to be one of the problems that you're going to have if you are not completely perpendicular to the object that you're trying to visualize, to measure. So we'll come back to our friend, the image over here. What do you guys think about this part, the intraatrial septum? seems missing, right? Seems like there's like an ASD over here. When you image this in another view, you actually see that the intra-atrial septum is intact, and it's probably really, really thin at this point. But since you are not perpendicular to the object of interest, that's why it's hard to sometimes make meaningful deductions from this. If you look at a subcostal view for the same image, where you can see that the intra-atrial septum, when the heart's kind of lying down flat and the intra-atrial septum is 90 degrees to where you're imaging it from, you can get rid of this. And that's why for your bubble studies, that's your proposed view. You're trying to do it in that particular view because you've got the best assessment of the structure of interest. You come across this the same kind of problem when you're trying to use color Doppler. If you try and image across the long axis of the aorta, it's very hard to use those Doppler signals, whether it is red or blue, because the flow in the aorta is going in a perpendicular direction to where you're trying to measure it with your color Doppler. When you're looking at valve regurgitations, you're going to also try and line yourself up in a way that you're absolutely parallel or 0 degrees to the direction of flow. 0 degrees or 180 degrees. It's the same thing. You essentially have to be parallel to the direction of flow, which you're going to try and evaluate. For example, if you're trying to evaluate tricuspid regurgitation, you're going to try and get yourself into parasternal long axis or vein flow view because you're perfectly aligned. Where you're able to align yourself kind of depends on the patient. It depends on the positioning of the patient, depends on what you think that day. If you think that parasternal long axis RV is not giving me, the inflow view is not giving me the best picture, and I think I could get a better picture in your apical 4-chamber view, then you use that, and that's where kind of, as your clinical knowledge kind of comes in and plays a part in deciding where your angle of incidence is the minimum. The next artifact that we're going to talk about is about aliasing. We see aliasing quite fairly frequently, and it usually happens when the pulse rate frequency is too slow for the Doppler signal being sampled. The Doppler signal that you're trying to sample is at a higher frequency, and hence when you try to capture it with your PRF, you feel or you see that the image kind of looks like flow is going in the opposite direction. It occurs if, obviously, like I said, the Doppler signal exceeds the Nyquist limit. A good example is going to be, so if this is all of us have kind of seen that phenomena that happens when you look at a car or the fins or the wings of an airplane. As the car picks up speed, or as an airplane wing starts rotating, after a certain speed, your eyes can't keep up with that. Same thing happens when you look at the ceiling fan. After the fan gets to a certain speed, when you look at it, it seems like the fan is slowly turning in the opposite direction. And that's essentially what aliasing does. Once the speed increases from that first box to second, maybe by the second, you can still keep up with it. Once it gets to the third, you can barely keep up with it. And then when it's really, really fast, it almost seems like it's going in the opposite direction. And that's what aliasing means. That's what aliasing does. This is an apical 5-chamber view, and you can see that, we're trying to measure the aortic outflow, and there is some AI, but the AI is too fast. The AI is too much for the probe to measure, and it's showing it on the opposite direction. It's coming on the other side of this thing. How do you get rid of it? It's kind of hard to get rid of aliasing. You can try and increase your Nyquist limit or your pulse repetition frequency, but this is limited by depth. There is usually not much you can do about it. You can try and use continuous wave Doppler or use a high PRF mode if possible, and that is something that you have access to. The next thing that we're going to talk about is a beam width artifact, another high yield for the boards. This image over here kind of demonstrates how your ultrasound beam is going to assess this area of interest. So imagine that the square is the area of interest. This is what you're really trying to image with your ultrasound transducer. The beam, like I said, doesn't really travel in a straight line. It kind of gets to an area of focus and then diverges from that point onwards. This black dot kind of lives outside your area of focus, but because your beam is diverging, when all this information gets back to the receiver, which is your transducer probe, because it lies around the same spot and you have a diverging beam, it gets superimposed on your area of interest. So what can happen is that there might be structures that are not in the actual frame or in the actual dimension that you're imaging in two-dimensional echocardiography. They might be, they are in the third dimension. They're either behind the screen or like outside towards you. But because the beam diverges, it picks it up and then transposes it in the area of your interest. You know, a good example is when you're trying to image the left atrial appendage, and that's why you got to be really careful when you're looking at the left atrial appendage, that you can start seeing some shadows that seem to be there in that left atrial appendage, and makes you really, really concerned. Well, is that a thrombus? Is that something that I need to be concerned about? Have a low threshold for using contrast to try and delineate these images, or try to change your angle to see if you can try and get rid of this aberrancy. Getting your focus on the area of interest is also another good way. You know, if you don't get the beam to diverge, if you are really looking at the left atrial appendage, trying to get your focus over there is also another strategy that you can use to get rid of these artifacts. Reverberations are very, frequently seen on the board exam, also very frequently seen in patient's chart and patient's echoes. The principle of reverberation is that the ultrasound beam, instead of going down and coming back up like this, the red arrow, goes down and hits two parallel strong reflectors. So, the easiest and the best example of this is going to be your pleural surface. You've got two pleura that are very close to each other. Ultrasound beam goes, hits the parietal pleura, and then some of it goes back, but then some of it actually goes through and hits the visceral pleura. And then it goes through a series of reverberations or bouncing before it makes it back to your receiver. The issue that happens with something like that is that now your ultrasound receiver is receiving, it's sent out one signal and it's receiving multiple signals, and these signals are at an equal distance, because each one of this bounce is going to be limited by the distance between these two structures, right? So you are going to see multiple forms of that reverberation that are equidistant from each other. So, if I show you a picture and show you that there is a mechanical mitral valve over there, ultrasound beam comes over here, hits the mechanical mitral valve, probably hits that blood metal interface, and then bounces a couple of times before it goes back up. You're going to see multiple equidistant lines in your field, which actually are not there. Another great example of this is the A lines that we see on lung ultrasonography. So A lines are equidistant lines that happen as a reverberation artifact from the pleural surface. There are really no such structures, just like there's really no such structure in the heart. The heart doesn't have, a stack of stairs sitting in it. The left ventricle doesn't have this. So, these are just artifacts that you should understand. And as long as you can tack them on to a particular source, you can say, oh yeah, this is there because the mechanical mitral valve is probably interfering with my ultrasound imaging. That's great. Also, what we see in this screen is shadowing, right where the struts are. The struts pretty much shadow out the ultrasound beam at this point, and you're not able to visualize anything in the far field, and you don't have any imaging in that field. Comet tails or ring downs artifacts are very similar to reverberation artifacts. I mean, these terminologies are kind of just used very interchangeably. Most people will agree that when they talk about reverberation artifacts, they are talking about a higher range reverberation. And when they're talking about comet tails, they're talking about a short range reverberation, which means that the lines are so close, are so tightly packed with each other that it doesn't look like a stack of stairs like we looked at it. It almost looks like a comet tail, or it looks like a shooting star, whatever you guys want to look at. Usually you'll see them at the lung pleura interface or with devices. So in this particular image, you can probably see some comet tails down here on this side of the screen, on the bottom side of the screen. This is an image of the aorta. You can also see that when the ultrasound beam hits the wall of the aorta, it will cause these comet tail artifacts. Basically, what these are is a stack of those stairs is really kind of compressed into a really tight order. a good example of this would be very similar to the B lines that we see on lung ultrasonography. B lines will happen when there is a little bit of pleural fluid or pulmonary edema that is present at the interface of the lung parenchyma when the ultrasound beam interacts with it. In that small bubble, you'll see that the ultrasound beam will go through that short range reverberation and give you these comet tails that are there. Also, you can see that there is a mirror image of the aorta up there. I mean, there's really no, but this is not a structure. This is just a mirror image of this. So sometimes you're going to have more than one artifact in your screen. And as long as you know the structure that you're imaging, the angle that you're imaging it at, you should be good and be able to navigate these artifacts. That's a loop of the comet tails. You can see it just kind of goes down, and I mean you could probably delineate that these are essentially a stack of lines just brought very close together, just compressed together. The next artifact that we're going to talk about is a mirror image artifact. Mirror image artifact is another clap and go answer on the board exams. What essentially happens is that the transducer thinks that it's going to send an ultrasound beam to the object and just make it back. Instead of just making it to the object, it also sends another ray of that beam along that fan that we talked about to another strong reflector. That strong reflector sends it to the object, back to the reflector, and sends it back to the transducer. A little too much to wrap our head around. So I'm going to try and explain that with the help of this picture. As you can see, the pericardium kind of acts as, the reflector for this. And there are other things, there is pleural fluid. There is going to be maybe some element of the lung that has got enough pulmonary edema in it that is going to act like that. If you have a ton of pleural effusion and your lung is completely collapsed, then it's going to be very hard to get a mirror image artifact because you really don't have that kind of reflecting surfaces around you. Here, it almost seems like there is a second heart that lives at the bottom of this image, and you have to adjust your depth. You kind of have to lower your depth to get rid of this aberrancy in your imaging. We're going to move on to shadowing. Shadowing is an easy one to identify. You lose your imaging deep to a highly attenuating structure. So once you hit a highly attenuating structure, you can have a valve, you can have a strut, something that is in the way, and it will cast a distal acoustic shadow. That it limits your visualizing ability in the area that is in your far field. Usually you can try and move your transducer around to try to get to another imaging window. If you're doing TEE, you try and either insert the TEE probe another centimeter or take it out another centimeter, try to image it from another dimension to try and get this out of your view. Usually, like I said, it's a highly attenuating structure, so calcium will do it. Different catheters in the heart, whether they are pacemaker or ICD wires, will do it, and obviously prosthetic valves and struts are going to do it. Near field artifact quizzes a lot of people. Thankfully, I don't have to deal with a lot of near field artifact in my life. I usually end up doing more TE than I do TTE. But for my cardiology colleagues and sonographers who are imaging people in the transthoracic ward, you can have this noise in your near field, and it happens because you have these high amplitude oscillations of the actual crystals of the transducer itself. It just creates a longer pulse length and decreases your axial resolution. So what it eventually ends up doing to your image is it creates like this haziness in the near field. It's kind of really hard to delineate the myocardium on this. You can see that the myocardium kind of moves, but this part is really, really hard to delineate and comment on. Well, is there any thrombus in there? Can I see spontaneous echo contrast in there? It's hard to make that assessment. I always tell people you kind of have to put everything in the same context, right? Like you have to look at the patient as a whole. Well, what is the contractility of the heart? Does the patient have a nidus for forming a thrombus? Is the blood velocity low? Is it an area of suspicion? Do I think that this could be true? And then, if you feel like some of those parameters are being hit and some of those red flags are going up, well then you got to use contrast imaging to get rid of this aberrancy in your field and make the correct judgment so that you're able to provide the accurate consultation to this patient. I mean, the apex of the heart is a spot where you can form thrombus, so you can't take this lightly. So that is your near field artifact. Shadowing, just like we looked in a previous loop, essentially happens when your ultrasound beam hits a high attenuating structure. You are not able to see distal to it. Foreshortening is a sin. So, foreshortening, I've seen a lot of people, again, this happens a lot in my field. I'm sure that happens in cardiology as well. I see people try and image the heart all the time, and the view is foreshortened. And they usually will say, well, they try and make comments on wall motion abnormality at that point. So when you're not cutting through the true apex of the heart, as is visualized as this dark green arrow, you are not really looking at the true apex of the heart. The apex should be at a fixed point. It thickens and thins, but it should not be bouncing up and down in the screen. So if that is happening, you're not going to be able to get the right kind of measurements from it, whether you're doing, your left ventricular measurements or you're doing your Simpson's biplane. I mean, your volume measurements are all going to be erroneous. At the same time, your wall motion assessment is also going to be erroneous. So make sure that you get the true apex of the heart and you are not looking at a foreshortened image. Sometimes, this can be something that comes up to you in your practice, and someone else, a sonographer, has imaged this patient. And if you are trying to look at an image that looks foreshortened, loop through a couple more. I mean, usually they do a very good job. If they can't get one, they'll get another one, and it's usually a couple of frames down the line. Enhancement artifact, we see some of this, not a whole lot. Usually happens when your image beam goes and hits a low attenuating structure. It's not an absolute high attenuating structure like calcium or a metallic valve. Usually you'll see cysts or fluid pockets that will cause these kind of artifacts. And what it actually does is that ultrasound beam gets attenuated after passing through that medium, or enhanced after passing through that medium. The image here shows that there's a little cyst. After the ultrasound beam goes through it, it actually increases in intensity. You can see that the amplitude is increased, and that image looks like it enhanced after it hit this fluid pocket. In our zone, most likely, we're probably not going to be looking at liver cysts. We're probably going to be looking at pericardial effusions and pleural effusions. So if you are imaging those would be things to look at. Rare, but can be rare. Electrocautery, like I said, will cause interference and artifacts into your frame. I see a lot of these when I'm working in the cardiac room. The surgeons are bowing the heart or working on the pericardium while we're imaging, and it will give us aberrancies in both spectral Doppler as well as color Doppler. So again, very easy to identify, and we know that this structure doesn't really live in the heart. This is just because we're getting electrocautery during this time. I mean, in this frame as well, you can see that there is aberrancy or artifact with the color Doppler when they bovie, and you can also catch a little bit of spectral Doppler interference on this side. We're getting close to being done. I think I've got a little more time. So side lobe artifacts, are going to be arc-like shapes at the radial distance. Usually, the reason why you have the side lobe artifact is your ultrasound beam fans out. Like I said, it's a big fan, and each one of those beams, because that fan is composed of a composite of different ultrasound beams, all pointed in the same direction, but the axis of those are slightly different from each other. When each one of that beam interacts with an object and comes back to the receiver separately, what you see is a series of these dots kind of just aligned right next to each other. If I show you this image, this probably will help explain a little better. Each one of these ultrasound beams interacts with this black dot separately. So this one is going to form this image, this one is going to form the second one, third one forms it over here. So eventually when your receiver puts all of these images together, it gives you a kind of a straight line across the heart. Sometimes you're going to be able to catch that in the third dimension. There might be a pacemaker wire, an ICD wire that is there, and it picks that up and shows you it in a spot where it doesn't belong, crossing anatomic structures. This is another way to kind of think about something and think if it is true or not true. Is it really crossing anatomical structures? Most of the times artifacts will cross anatomical structures. Most of the times real objects do not cross anatomical structures. So if you are looking at an image like this, where you have the pacemaker wire that kind of seems to go across the base of the heart, it's probably not true. It's probably not where you would want this to be. So that is going to be your side lobe artifact. The last artifact that I'm going to talk about is going to be an artifact that we see in three-dimensional echocardiography. We see that when we're trying to do a multiple beat acquisition, and we're trying to stitch all those beats together. You can get a stitching artifact, and that's again like easy to identify. If that shows up on the boards, that's an easy clap and go answer. What ends up happening is that the ultrasound machine acquires these different data sets and then kind of pastes them together. If there is anything that is changing the positioning of this probe and changing the positioning of the patient, it is going to now cause an aberrancy in the stitch. So if the patient moves, if your ultrasound probe moves, or the way that this ultrasound machine is gating all these together moves. So the patient goes into AFib, right? Like it's gated off the RR interval. And if the patient goes into AFib and those intervals change, then you're going to have the stitching artifact. Easy to identify. You just see these, lines that limit your visualization. The reason why people go to a multi-beat acquisition is to improve the resolution. So, I guess the easy way to get rid of this is just go to a one-beat acquisition. It will decrease your resolution, but it will get rid of the artifact. The other way is going to be to try and limit motion. Try and see if the patient can hold their breath, try not to move, make sure that's not the time that people are, moving the patient or positioning, so on and so forth. So that's kind of the end of my chat. We're going to discuss, a few questions, and then after that, I'll be open to any questions that you guys might have. So the first one is, which following techniques can help distinguish an LV thrombus from an artifact, specifically talking about near field clutter. You can increase the depth, you can increase the frequency, decrease the depth, use multiple views, or use contrast, use a single view, and then increase the MI.
We have a few answers for B.
B it is. Man, you guys are good. Someone would think you're a cardiologist or something. Okay, we're going to move on to the second one, which is true regarding a side lobe artifact. Involve the presence of a weakly reflective object close to the central beam. Side beam artifact, image appears in the wrong location, but in the same direction of the main beam. And then, we've got side lobe artifacts, echoes returned from highly reflective objects located within a pathway. And then all energy emitted from an ultrasound transducer remains within the central beam. Sorry for the wordy question. I got some pictures coming up.
We have a few votes for C.
Okay, so the answer here is actually B. The image appears in the wrong location, but in the same direction, remember? So you're going to, if you go back to like side beam artifact, you're going to have a wrong location, but it actually is in the same direction of the beam. They are returned from a highly reflective object. The moment that shows up, you should start thinking about mirror image, because that's where the high reflection is going to be, right? In side beam, the object is normal in their reflection. They're really not like a strong reflector. It's just that they are in that direction. They just happen to be there. Does that make sense? Clarify things a little bit. It's tricky. You just kind of have to use these keywords. Is it like a high reflector or a small reflector? Okay, we'll go on and look at the third one. Okay, so which one of the following statements regarding mirror image artifact in spectral Doppler echocardiography is correct? If your gain is too low, do you develop a symmetrical spectral image on the opposite side of the baseline. Mirror image is more intense. It can be reduced by increasing the power. You guys got this one.
We have a few votes for B.
Oh, there you go. Okay, right. It is B, right? You know, you can't have it when the Doppler gains are set too low. I mean, that would be one way to actually fix it, is to decrease your Doppler gain. The mirror image cannot really be more intense because based off of the principle of reflection, it is formed as a reflection, and a reflection can't really be brighter than the original image. Like, you are going to have some degree of attenuation as that ultrasound beam passes through, right? And then obviously it can be reduced by increasing the power is wrong, because that will only make it more. So you probably want to decrease your gain and decrease your power, just like we discussed. So excellent. Okay, so some pictures. So what kind of imaging artifact is that? Mirror image, right? We just talked about it. It's right there. It's underneath. We've got the heart up here. This is like, you know, your home base. This is parasternal long axis, and then now you've got like this second image forming underneath that pericardium. I mean, so this is partly your true image, and this is your artifact. Good. All right. Then this is the last one. Identify the artifact shown in the echo image. So is it a comet tail? Is it a mirror image? Is it a side lobe? Or do you think it's a thrombus? We're talking about this thing.
We have many votes for D, some votes for C.
All right. Yes, and this is why I kept this as the last example, right? Like, I know I put the left atrial appendage as a side lobe artifact, but we should not, you know, lose the forest amongst the trees. This is a thrombus. I mean, this is, you know, glaring at us. It should not, just because we've you know, listened to a talk and we've read it in a book, and every time we look at a parasternal long axis, that we start imagining that there is going to be a mirror image underneath it, or we look at a left atrial appendage and we see a true thrombus there, and we say, oh no, that's just like, you know, a side lobe artifact. You kind of have to really look beyond you know, what you've been taught, and roll all of that into your assessment of the patient. So this is a true thrombus. It's pretty evident. The artifact is going to not justify this. So it's a great question. I mean, I'm glad that we discussed this, and just because I said side lobe artifacts happens in the left atrial appendage should not be the reason you guys ignore this. Looking through, this is a thrombus. I'm gonna, you know, talk about a couple of papers if people want to look at this. The third one by Bertrand was a very useful one as we went around designing this chat. And I leave you with this thought, because I think this is why life is just in general more busy and more stressful. It's because, you know, back in the day, they didn't have a lot of stuff. So they thought, oh, I only have like M mode and B mode. And now there are like all of these things that show up. Even though technology is advanced, it's just kind of caused a lot of aberrancies, a lot of artifacts that now show up, and that, you know, you guys have to deal with. As long as you are able to keep everything in the clinical context, you know, the patient who has the thrombus that we just looked at also has a low ejection fraction. You're not able to say, well, yeah, this looks like it's like, yeah, maybe 15, 20% EF. There's wall motion abnormality. There is spontaneous echo contrast or smoke in the left atrium. All of those things should make you think, well, that this requires, you know, a contrast evaluation versus, you know, something that is trivial, or thinking, well, yeah, I don't really think this is a thrombus. This could be pectoral muscle. This could be something else that I'm not really able to clearly visualize. That you could make that assessment. So we got a few minutes if there are any questions. I'd be happy to field any questions. Thank you guys for this opportunity, and hope you take away a few things from this.
Thank you very much, Dr. Sharma. That was an excellent talk. We have 2 questions. I think you did cover them, but since we have a few minutes, can you show examples of side lobe and beam width artifact again?
Go back to them again.
Yes.
Okay, yeah, of course I can do that. Hold on, let's go back to side lobe and beam width are kind of very similar. You know, a lot of times people think that they are about the same, and I actually do think that they're about the same. So here you go. So here you are. I'm gonna make this bigger so that everyone can see. So your beam width is going to be, you know, you have one object and it's going to be interposed in your area of interest, right? You guys can see this. Whereas when you look at a side lobe artifact, you are talking about a similar principle, but what is happening is that this object is being hit by different parts of this ultrasound beam. So instead of one circle down here, you're going to have a series of circles in a line. If I go back to this first image, let me show you. There is this first image that I kind of wanted to show you. So this is beam width, right? Let's see if we can run this. I think it was, where did that, oh, there it is. You guys see this?
Yes.
So you see how like you're now seeing a series of these things kind of like drawn across as a line right up here. Oh, too fast. So that would kind of be like, you know, like a side lobe, grading lobe, whatever you guys want to call it. Whereas if you had that, the reason why I brought up that left atrial appendage, and let's go to that one again, is because it usually is just like one thing that is showing up. You don't have this line across. When you have this line going across, usually that is going to be a side lobe artifact because you had multiple of those ultrasound beams interact with that object. So great question, confuses a lot of people. We're gonna look at it one more time, okay? So here's your beam width. One thing gets interacted with this diverging ultrasound beam. The ultrasound beam picks it up and puts it in that area of interest, but it's still one object, right? So beam width will kind of put you in that left atrial appendage, right? You're thinking I have something here, but it's not a line that's being drawn across, right? We also don't have that big goomba coming out of the left atrial appendage, which is like clearly a thrombus. I mean, this could be a thrombus too, right? We don't know until you do some better imaging and use contrast. Now, if you go to side lobe, which is right here, the premise is the same, right? So there is an area of interest and then there's an external object, but different ultrasound beams are going to pick this up separately and then draw a line across your area of interest. This goes back to that 4-chamber view with that apex being like, you know, lined off. Does that add up? Does that answer the question?
Yes.
It is confusing. So I mean, I am with you guys.
And the last question was, can you please show the reference slide again?
Oh, of course, yes. Here you go. The one by Bertrand Levine is a really good one.
Thank you very much, Archit. That was an amazing review of a very difficult topic. So I really appreciate your contribution to this topic and to this conference. Thank you again.
Oh, happy to. Thank you. Thanks, guys.
Going to move on to our next speaker for today, Dr. Richard Markers. Dr. Richard Markers is one of the nation's leading experts in echo. He's a native of South Africa, received his medical degree from the University of Witwatersrand Medical School in Johannesburg. I hope I'm saying that right. He then completed surgery and internal medicine internships at Johannesburg General Hospital, senior internship in surgery, anesthesiology, and a residency in internal medicine at Johannesburg Group of Teaching Hospitals. After 2 years of military service, Dr. Marcus completed a cardiac research fellowship at the University of Witwatersrand, a clinical cardiology fellowship at the Johannesburg Group of Teaching Hospitals, and a clinical and research fellowship at the University of Chicago Medical Center. He has held numerous academic and clinical appointments and has published extensively in the areas of valvular heart disease LV function, ventricular arterial coupling, and Doppler echo. He joined Iowa Heart Center in 1996. He's board certified in cardiology echo and currently practices at Iowa Heart Center's West University Clinic in West Des Moines. And it is my great pleasure to introduce him. He is going to be talking to us about aortic stenosis. As you all know, this is the last talk for today. The questions keep coming up about recordings. I'm going to share my screen one more time. So as soon as the lectures are done, hopefully early next week, we should have the recordings up. They will be on our website at iowaacc.org echo board prep lectures. I'm going to put the link in the chat box, but we'll also include it in the future emails if you need to look in here. As long as the speakers are agreeable, we'll have the recordings, and as long as they're willing to share their slides, we'll also upload the slides so you can use them for your review. And as I mentioned in the beginning, if you're planning to do your echo boards, please spend some time and look up general cardiology, because a lot of these topics, a lot of these questions do come from general cardiology. So without any further delay, I'll let Dr. Marcus take over. Rick, you with us? I think you're muted, Rick. We can't hear you.
Can you hear me now?
Yes, perfect.
Can you see the images?
We can. There's an echo coming.
Can you guys see the images?
Yes, we can see the images.
I'm not getting a response from them.
We can see the images, Dr. Marcus.
Before I start, I just want to make sure you can hear me, and I don't have any response from you.
We can hear you and we can see the images.
Jay, I can see you talking, but I don't hear you.
I think your sound is low. Maybe I'll just message him.
Can you hear me?
Yes.
Okay, perfect. All right. Dr. Ashwath, thank you so much for inviting me to participate in this. It's really an honor for me. I've been in private practice for going on 25 years now. And towards the end of my career now, I'm really finding much joy in spending a lot of my time teaching. So I hope you enjoy this talk, and I hope it's beneficial to you in preparing for your boards. I have no disclosures, and I have a career of over 40 years of acknowledgements, which I obviously can't enumerate. So here are some questions for you to consider. Sorry, can you get rid of that at the top of the screen? Yeah, click more. All right, here are some questions for you to consider. A patient in whom a systolic murmur was detected at the left sternal border is referred for Doppler echocardiographic examination, which reveals an aortic valve orifice area of 0.8 centimeters squared by continuity equation, transaortic mean systolic gradient of 18 millimeters mercury, and a dimensionless index or Doppler velocity index of 0.45. Which of the following is the likeliest diagnosis? Severe aortic stenosis with severe mitral regurgitation, mild aortic stenosis with underestimation of LVOT diameter, severe aortic stenosis with LV ejection fraction less than 50%, or severe aortic stenosis with small LV cavity and low transaortic flow.
We have multiple answers for B.
No, we're going to answer them at the end of the talk. Sorry. We'll come back to them at the end of the talk. Okay, which of the following causes of aortic stenosis is or are associated with aortopathy? Bicuspid aortic valve, unicuspid aortic valve, supravalvular or supravalvular aortic stenosis, subvalvular aortic stenosis. Only A is correct, A and B are correct, A, B, and C are correct, or all are correct. We'll come back to it. And if you listen to the talk, you should be able to answer all these questions by the time we get to the end. Next, causes of low flow, low gradient in a patient with severe aortic stenosis include severe mitral regurgitation, severe tricuspid regurgitation, LV systolic dysfunction, underestimation of LVOT diameter. Only A is correct, A and B are correct, A, B, and C are correct, or all are correct. And lastly, a pretty long stem here. A 72-year-old female patient with mild rheumatic aortic stenosis underwent mitral valve replacement with a 27mm stented xenograft for treatment of symptomatic severe rheumatic mitral regurgitation and stenosis. 10 years later, she presented with increasing exertional dyspnea and prominent systolic murmurs at the apex and at the left sternal border. The transthoracic echocardiogram revealed a peak transaortic velocity of 4.5 meters per second, a mean transaortic gradient 45 millimeters mercury, Doppler velocity index of 0.4, aortic valve orifice area of 1.5 centimeters squared, apparent mild regurgitation. What is the most likely explanation for these findings? Severe rheumatic aortic stenosis, hemodynamically significant mitral regurgitation, subvalvular LVOT gradient, and mild aortic stenosis, severe mitral regurgitation with mistaken location of systolic gradients and no aortic stenosis, or overestimation of LVOT diameter with severe aortic stenosis. Okay, the learning objectives here are manifold, and I can tell you I spent the last week trying to cut down the information that I wanted to share with you, which I think is important both for your board exam, but also for your practice in cardiology in general. And this is the best I've done, so bear with me. First, we're going to discuss the hemodynamic parameters that we look at using transthoracic echocardiography to assess the hemodynamic severity of aortic stenosis. There are 4 of these. First, we look at flow velocity across the LVOT and aortic valve. Then we look at pressure gradient across the LVOT and the aortic valve. And then we determine aortic valve orifice area, which depends entirely, which itself determines the pressure flow relation. Let me explain what I mean by that, because it's got great significance in respect of accurate diagnosis. For any given aortic valve orifice area, let's call it x square centimeters, there's a quadratic exponential relation between pressure, transaortic gradient in this instance, and flow, stroke volume in this instant, that is determined by Newtonian physics. P is proportional to F squared. Now, since it's pressure that drives flow, the pressure flow relation is more physiologically expressed with pressure, the independent variable, as flow is proportional to the square root of pressure, expressed by this graph. Now, as the aortic valve area increases to a value greater than x square centimeters, the pressure or transaortic gradient needed to drive a given flow or stroke volume decreases. And conversely, as the aortic valve area decreases to a value less than x square centimeters, the pressure or transaortic gradient needed to drive a given flow or stroke volume increases. And it's important immediately to remember that since we're using flow, which we determine, and gradient, which we determine, and we're using the pressure flow relation to come up with the aortic valve orifice area, at low flows and low gradients, our ability to differentiate or dissect apart different orifice areas is attenuated. Just remember that fact, it'll come up later. The final parameter that we use to assess severity of aortic stenosis is the Doppler velocity, also called dimensionless index, which is a marker of flow acceleration across the aortic valve from LVOT to ascending aorta. Now, I'm just presenting to you a grid or matrix here that we're going to be using recurrently throughout this talk. If you look at the left-hand column, the 4 parameters that I just described to you are annotated there. And then serially in the yellow, orange, and red columns, you can see the ranges of values for each of those parameters in aortic stenosis that's classified as mild, moderate, or severe. Those numbers are important for you to remember for the board exam. Now we're going to discuss some pathophysiology. Each one of these concepts that I'm discussing with you before we get into the clinical meat of the subject, you'll find are important for you to understand what you're supposed to look for in the echocardiogram. So as far as pathophysiology goes, the primary function of the ventricle is to pump blood to the peripheral organs. And the ability of the ventricle to pump or contract, measured as strain, is limited by wall stress, which is the intramyocardial forces that resist contraction. And this is called the stress-strain relation, annotated schematically here. Now, the wall stress on the horizontal axis of that schematic is dependent upon the intraventricular pressure, the ventricular dimension, and inversely dependent on the left ventricular wall thickness, as represented there. The strain or fractional change in fiber length, which by the way, can be measured as a unidimensional variable, such as using global longitudinal strain, as a two-dimensional variable exemplified in the shortening fraction, which is represented here, dd minus ds over dd, diastolic minus systolic over diastolic dimensions, or as a three-dimensional variable, as in the ejection fraction. And that is on the vertical axis. So here we've used the two-dimensional example of that. Obstruction to outflow now causes an increased intraventricular pressure and hence an increase in the wall stress with reduced strain, as annotated here. Compensatory response is concentric left ventricular hypertrophy to increase wall thickness, normalize wall stress, and therefore preserve strain or systolic function, as annotated here. Now, when the compensatory hypertrophy capacity is overwhelmed, contractile function can no longer overcome wall stress, the ventricle dilates, and systolic function or strain declines, as annotated here. And these are the cardiac target organ responses to aortic stenosis that we're going to examine Doppler echocardiographically further on in this talk. Now, what is the etiology of aortic stenosis? Well, it may be supravalvular, valvular, or subvalvular. Let's start off with supravalvular aortic stenosis. The genetics of this condition is that it's a systemic elastin arteriopathy due to a microdeletion or point mutation of the elastin gene on chromosome 7. It's autosomally dominant, inherited, with variable expressivity, and 70% of the cases are syndromic, with the eponym Williams-Buren syndrome attached. Note that 50% of these patients have bicuspid aortic valves as well. The narrowing may be discrete or localized, or there may be tubular hypoplasia. Clinical features are that you might feel a thrill in the suprasternal notch or over the right carotid, and A2, instead of being soft in severe stenosis, may be loud as the supraaortic pressure pushes the valve down, closes the valve forcefully. The Williams-Buren syndrome is characterized by pre- and postnatal growth retardation, short stature, mental deficiency, the elfin facies with a high forehead and a micrognathia with a pointy chin, and social disinhibition, the friendliest patients you'll ever meet, as well as hypercalcemia. The diagnosis is based on two-dimensional echocardiography to first suspect this condition, where you see supravalvular narrowing of the ascending aorta. You can then assess the function across this suspected narrowing with Doppler echocardiography, which will reveal a high velocity supraaortic flow. But ultimately, you need CT angiogram or MR angiogram to define anatomy and anatomic relations. So here are some images. This is a parasternal long axis image, and you can see narrowing of the supravalvular aorta just above the sinuses of Valsalva, annotated by the yellow arrow, with the valve level annotated by the white arrow. This is the CT angiographic analog. I won't spend any more time on that. And this is the aortographic analog obtained in the cardiac catheterization laboratory, where you can see the negative contrast at the level of the aortic valve annotated by the white arrows and the supravalvular stenosis annotated by the yellow arrows. How do we treat this condition? Well, if it's severe, then you need surgery, and the surgery may be an aortoplasty or a conduit. Now let's get on to subvalvular aortic stenosis. I know I'm going quite fast, but you'll have the content ultimately, and we do need to cover all of this. I couldn't cut it any shorter. So the type of narrowing may be a discrete membrane or ridge, or a tunnel, or it may be a narrowing due to hypertrophic cardiopathy with idiopathic hypertrophic subaortic stenosis. These patients, as you well know, may have a rapid carotid upstroke instead of a slow rising carotid pulse, despite severe obstruction. The aortic valve itself is often normal. and A2 is preserved rather than soft and is not delayed. There's a systolic murmur at the left sternal border that's lower than with valvular aortic stenosis. The murmur may be dynamic if there's a dynamic component to the obstruction, increasing with standing or Valsalva and decreasing with hand grip or squatting. And in the case of subvalvular aortic stenosis, there's often concurrent aortic regurgitation due to the turbulent high velocity flow impinging on the aortic valve leaflets. So this is a two-dimensional echocardiogram showing you, as arrowed in red, a subvalvular membrane or narrowing in the LVOT. And often the aortic valve anatomy is normal with normal leaflet motion. This is the functional assessment of the subvalvular aortic stenosis, the Doppler echocardiogram showing high velocity subaortic flow acceleration with a subvalvular gradient, which may be dynamic, shown in the right panel, and which is often associated with aortic regurgitation, shown in the left panel. Now beware with these cases, inappropriate diagnosis of valvular aortic stenosis when there are discordant Doppler echocardiographic parameters. Remember those 4 parameters we alluded to earlier, the valve area, the Doppler velocity index, the mean gradient, and the peak velocity. Note that with significant subvalvular obstruction or severe subvalvular obstruction, you have gradients and peak flow velocities in the severe range, but the aortic valve area and Doppler velocity index are in the mild or moderate range. And when you see that pattern, which in our presentation later on, you'll see we call this particular one pattern 2, the subaortic, the diagnosis, the pattern tells you that the underlying diagnosis is a subaortic membrane tunnel or ridge, or idiopathic hypertrophic subaortic stenosis, or a high output state. Now, you usually need in this condition a TEE to be 100% certain of the pathologic anatomy before you send the surgeon to do something. And this is a TEE showing you a subvalvular or subaortic membrane, annotated here by the yellow arrow. And in this particular case, you can see that there's also subaortic septal thickening. And this patient may well need resection of the membrane plus a limited myectomy to correct this condition. So what is the treatment? The treatment is surgery if it's indicated by the severity of the aortic stenosis, or if there's aortic regurgitation that is more than mild and that appears to be progressing. And the surgery is resection of the membrane tunnel or ridge and or myectomy, which may stop the progression of the aortic regurgitation and therefore obviate the later need for aortic valve intervention. Finally, we come to valvular aortic stenosis. Now, this may be congenital, affecting a bicuspid aortic valve, which occurs in 1 to 2% of the population, a unicuspid aortic valve, or a quadricuspid aortic valve. Or it may be acquired, affecting a trileaflet aortic valve. Now, stenosis of a bicuspid aortic valve accounts for 70% of aortic valve replacements performed for aortic stenosis in patients less than 70 years, but only 40% of aortic valve replacements for aortic stenosis in patients more than 70 years. Conversely, stenosis of a trileaflet valve accounts for only 30% of aortic valve replacements for aortic stenosis in patients less than 70 years, but 60% of aortic valve replacements for aortic stenosis in patients more than 70 years. My big message from this particular image is that when you have a patient in the lab and they have severe aortic stenosis and they are less than 70 years old, you should look for a congenital abnormality. And it is very important because there are many associated pathologies that need to be identified and interrogated in that group of patients. So now the relation to the age at the time of presentation. If they're less than 30 years, you should suspect congenital stenosis of unicuspid or bicuspid valve. If they're 40 to 70 years, you should suspect degenerative stenosis of a bicuspid valve, or in developing countries, rheumatic disease. And if they're more than 70 years, you should suspect senile degenerative stenosis of a trileaflet valve. Let's now get on to the anatomic pathology. Okay, this is a normal aortic valve, open during systole on the left and closed during diastole on the right. I want you to note, because you're going to compare in subsequent slides, note on this slide, the thin diaphanous transparent leaflets with unrestricted excursion. Now, in a normal aortic valve, the orifice diameter is approximately 2 centimeters. And the orifice area is 3 to 4 square centimeters. This is a parasternal short axis image showing you a normal tri-leaflet aortic valve. I don't know if you can see my mouse here, but always remember, and this question comes up, always remember that it is the non-coronary cusp which abuts on the interatrial septum. And always in transthoracic imaging, it's exactly the opposite in TEE, but in transthoracic imaging, whichever view they show you, the non-coronary cusp abuts on the interatrial septum. Go clockwise from that cusp, clockwise in a transthoracic, and you'll be at the right coronary cusp. Clockwise again will take you to the left coronary cusp. And it's exactly the opposite with TEE, but I'm not going to confuse you by repeating that. Now, note also that when a normal valve opens, the opening is triangular. Can you see when the valve opens that triangular shape of the orifice? Now, in degenerative disease of a tri-leaflet valve, or of any valve, in degenerative disease, the calcification begins along the flexion line of the cusps at their bases. And progressive calcification leads to leaflet immobilization and aortic stenosis. And this process is analogous to vascular calcification that is part of atherogenesis. Here is a pathologic specimen showing senile calcific degenerative disease involving a thickened tri-leaflet aortic valve with restricted leaflet excursion. In contrast, the anatomic pathology that accounts for congenital stenosis is due to a number of factors. First of all, the variant anatomy per se. The opening of the valve might in and of itself, associated with the anatomic abnormality, be small. Second, the leaflets themselves are frequently dysplastic and thickened with reduced excursion accounting for stenosis. Third, the commissures of the valves may be fused, limiting the degree of opening. And finally, there may over a period of time be superimposed degenerative change, and the functional severity determines the age of presentation. So here you can see an echocardiographic image on the left and a pathologic specimen on the right showing congenital aortic stenosis due to a thickened dysplastic unicuspid aortic valve. The left panel showing the parasternal short axis 2D image, the right panel showing the surgical specimen. And here's this congenital aortic stenosis due to thickened dysplastic unicuspid aortic valve in real time in a parasternal short axis image. Now here you can see the anatomic pathology associated with the bicuspid aortic valve with commissural fusion and slightly thickened dysplastic leaflets, but no degenerative change at this time. And this is a parasternal short axis 2D image showing you congenital aortic stenosis in real time due to bicuspid aortic valve with some commissural fusion. Note the difference in the opening morphology of this valve. It has a fish mouth opening during systole. Now, in some of these bicuspid aortic valves, one has superimposed degenerative change, and that can just aggravate whatever stenosis was present previously. And you can see the difference between this and the previous pathologic specimen that I showed. This is a transesophageal echocardiogram showing you a quadricuspid aortic valve. Here you can see some commissural fusion between the cusps at the commissure between the cusps at 5 o'clock and at 3 o'clock, accounting for the aortic stenosis. Now, when you find bicuspid aortic valve, it is important always to look for associated pathology, which is not infrequent, because there is aortopathy with aortic dilatation in 25% of patients, which has been attributed both to genetic and to hemodynamic sequelae, both to genetic factors and to hemodynamic sequelae of aortic valve disease. And the pathologic hallmark of this condition is a cystic medial necrosis that's characterized by accumulation of basophilic ground substance in the medial layer with cystic lesions and apoptosis of vascular smooth muscle cells shown here. You can see the cystic medial necrosis with basophilic ground substance, cystic lesions, and paucity of vascular smooth muscle cells in the ascending aorta of a 47-year-old man who presented with ascending aortic aneurysm that was associated with bicuspid aortic valve and mixed aortic valve disease. Now, important, and this is a question that could come up, is the aortopathy due to cystic medial necrosis is also associated with unicuspid valves and quadricuspid aortic valves. A second associated pathology in the presence of bicuspid aortic valve is aortic coarctation, which occurs in 5 to 15% of patients. I always like to simplify this by reminding my fellows that coarctation is associated with bicuspid aortic valve in approximately 70% of cases. It's somewhere between 60 and 85%. Whereas aortic coarctation is associated with bicuspid aortic valves in 7%. So I have the 770 rule, which makes it easy to remember the range of prevalence of this condition, but it's not a low prevalence rate. So here in the lower panel, you can see a CW Doppler from the suprasternal window in a patient with bicuspid aortic valve and aortic coarctation. The holodiastolic gradient is critical to this diagnosis, and you can see a peak systolic gradient of 53 millimeters mercury. So always look for a diastolic gradient in these patients. Now, this associated aortopathy must be taken seriously and managed. The entire aorta must be scanned with CTA or MR angiography. First-degree relatives must be screened, and one must track the progress of this aortic dilatation with 2D echo or CT, and surgery will be indicated if aortic root or ascending aortic diameter increases to more than 5.5 centimeters, or if the diameter increases by more than 5 millimeters per year, or if the diameter is more than 4.5 centimeters and AVR is required. You may say, why am I going into all that here? Well, I'm going into it because it's your responsibility as the echocardiographer to alert the referring physicians to these facts. So you're the one that sees a bicuspid aortic valve. As you know well, the threshold for operating on ascending aorta or aortic root aneurysms is 6 centimeters in the presence of a tri-leaflet valve. So you need to alert your colleagues to this. In addition, I have seen in my 40 plus years, patients going to surgery for aortic valve replacement with ascending aortic diameters of 4.5 centimeters, which are not intervened upon. So be aware of that and help your colleagues with that. Now, rheumatic aortic stenosis is primarily due to commissural fusion. We don't see much of that here anymore. In the developing world, that's still prevalent. So it's due to commissural fusion at the free margins of these inflamed, sticky rheumatic leaflets with subsequent degenerative change. And this is a pathologic specimen of a rheumatic tri-leaflet aortic valve with commissural fusion and restricted leaflet excursion. Now let's get on to the clinical presentation of severe aortic stenosis, and we're going to do this pretty briefly. So when patients have severe aortic stenosis, many of them, if not most of them, are going to tell you that they feel a little bit fatigued. You might say this is due to reduced capacity to increase cardiac output if you're explaining it on the basis of the aortic stenosis. They have exertional dyspnea. They almost all have LV diastolic dysfunction based on that pathophysiology that I described to you earlier. And they have decreased exercise tolerance, which may be due to both of the above. But those symptoms are symptoms which most 85-year-old patients might complain of, whether they've got aortic stenosis or not. The important symptoms that are the harbingers of sudden cardiac death are exertional dyspnea that's associated with LV systolic and diastolic dysfunction. Angina pectoris, although it should also be noted that 50% do have associated obstructive coronary artery disease, and exertional syncope, for which there are multiple putative mechanisms that I could not include for want of time. We'll come back to some of that in due course, but let's go on now with the Doppler echocardiographic assessment. So on the basis of what I've told you, you will use Doppler echocardiography to examine the valve pathologic anatomy and draw conclusions concerning prognosis and follow-up. You'll look at the LV cardiac target organ response to changing wall stress, specifically LV hypertrophy, associated diastolic dysfunction, and then ultimately systolic dysfunction. And you will assess the hemodynamics of transaortic flow using the 4 key parameters to which we alluded: transaortic systolic flow velocity, transaortic systolic gradient, effective valve orifice area, and the Doppler velocity index. Now, note that we're now going to be focusing on severe aortic stenosis. The Doppler echocardiographic assessment thereof. So remember, in the hemodynamic assessment of severe aortic stenosis, we expect to find a peak transaortic systolic flow velocity of more than 4 meters per second. These values should be familiar to you before you go into your board exam. A transaortic mean systolic gradient of more than 40 millimeters mercury, provided forward flow is normal. An effective aortic orifice area of less than 1.0 centimeters squared, or an aortic valve area index of less than 0.6 centimeters squared per meter squared. And before we go any further, I'm not focusing today on discussing with you the principles of the modified Bernoulli equation and how we come up with pressure gradients, or for that matter, even the details of the way we assess valve area. But I'm going to just briefly allude to this because it is central to this whole argument that we're presenting. So basically, this is the way that we assess aortic valve area in most instances using the continuity equation. The continuity equation's principle is that the flow across the LV outflow tract is identical to the flow across the aortic valve. The flow across the outflow tract is the product of the cross-sectional area of the LV outflow tract and the velocity time integral of the flow at that point. So clearly errors can arise if you incorrectly measure LVOT diameter, because we get the cross-sectional area assuming that the flow is going through a circular orifice. We determine the cross-sectional area as 0.785 times diameter squared, or pi times radius squared. And so the assumption is that the area is circular, but we have to measure that area at exactly the same point where we place our region of interest using our range-sensitive pulsed wave Doppler beam. Because if we put the Doppler beam lower down or higher up, but measure this diameter, we are going to get a flawed estimate of the stroke volume going across the LVOT. Then we say that the blood flow or stroke volume across the aortic valve is the aortic valve area multiplied by the VTI across the aortic valve. And then we come up with, which you're all familiar, that 0.785 times diameter squared times VTI across LVOT divided by VTI across aortic valve is aortic valve area. Note that the ratio of VTI across LVOT to VTI across the aortic valve is the very dimensionless index or Doppler velocity index that we alluded to earlier. So the Doppler velocity index multiplied by the cross-sectional area of the LVOT is the aortic valve area. I'm just playing with numbers here, but it becomes very important in understanding discordances that arise later on. So in your hemodynamic assessment, we've described the peak flow velocity, the transaortic mean gradient, and effective orifice area that defines severe aortic stenosis. And now we come to the Doppler velocity index that defines severe aortic stenosis, which in our lab, we use a number of less than 0.3, but I don't want you to use that number in your board exam, because in the board exam, they have not changed the original Doppler velocity index denoting severe aortic stenosis from 0.25. And you can see from what I showed you on the previous slide, just going back to it, that the aortic valve area is the Doppler velocity index multiplied by the cross-sectional area across the LVOT. Well, when we first started with Doppler many years ago, severe aortic stenosis was defined as an aortic valve orifice area of less than 0.8 centimeters squared. And it was at that time that we came up with the Doppler velocity index indicating severe aortic stenosis of less than 0.25. Well, if you take those two numbers, you'll see that the assumed cross-sectional area of LVOT at that time was 3.2 centimeters squared. Many years later, we changed severe aortic stenosis for reasons that I'm not going to go into now to a value of less than 1.0 centimeters squared. Well, if we apply the same cross-sectional area, and there's no reason for that to have changed, cross-sectional area that we had earlier, you will see that the DVI, which should signify severe aortic stenosis, is less than 0.31. So that's why in our laboratory, and I'm going to be referring to that in the matrices that I show you going forward, but when you come to the board exam, DVI of severe aortic stenosis is less than 0.25. Now, for definitive diagnosis, these 4 hemodynamic parameters should be concordance. And if they're not concordant, discordance should be explained before you willy-nilly send somebody off to have their aortic valve replaced. So I'm taking you back to the matrix. The 4 parameters are shown in the left-hand column, in the left-hand panel. The ranges of values for each of those parameters for mild, moderate, and severe aortic stenosis are shown in the yellow, orange, and red panels respectively, and the interrupted lines surrounding the Doppler velocity index for severe aortic stenosis is just to remind you in your exam to use less than 0.25. So now if you're examining a patient and all 4 parameters are in the severe range, well, then they're concordant for aortic stenosis. And you could almost use a computer to tell you what to do. Because if the hemodynamic parameters are concordant by transthoracic echocardiography, the diagnosis is confirmed and the management is according to GDMT guidelines, guideline-directed medical therapy. Now, if the hemodynamic parameters are discordant, which unfortunately is all too often the case, you should remember that in some people say 23%, but certainly in at least 20% of patients with severe aortic stenosis, the apical views for acquisition of the CW Doppler peak gradients across that valve and mean gradients across the valve do not give you the maximal values. You have to consider using suprasternal or right parasternal views to get the maximum gradients. So it's not infrequent that the numbers are somewhat discordant for a number of reasons. And then you require supplementary testing. And now we're going to discuss what this testing should be. Right. So we've shown you pattern 1 is the concordant pattern. And I'm going to now go through another 4 patterns of discordant data, which are easy to recognize. And you should immediately be saying to yourself, well, what if there is more than one etiology for the discordance of the data? That is true and it's possible. But once you understand these 4 patterns, you will easily be able to dissect out what's going on in every one of your patients, I assure you. So the first discordant pattern is the pattern where the gradient and the peak velocity are in the severe range, but the valve area and dimensionless index are in the mild or moderate range. Remember, we're only talking about patients in whom we're suspecting severe aortic stenosis here, which means at least one of these parameters has got to be in the severe range. So what is the cause of this discordance? Well, the mechanism here is what we've already alluded to. It's subvalvular flow acceleration. And that subvalvular flow acceleration, you now know, may be due to a HOCM, subvalvular membrane, tunnel or ridge, or a high output state. So once you get that discordance, you need to go back to your patient and you may need additional transthoracic imaging or a TEE to define whether or not you think there is HOCM in the patient, because that might have been missed, especially if it's not severe. If you're suspecting a subvalvular membrane, TEE is a spectacular technology to diagnose that. You may want to go back to the cardiac catheter or go to the cardiac catheterization laboratory, especially if it's severe and the patient is going to need intervention on the membrane. And in the cardiac catheterization laboratory, if you cross the valve, you'll be able to find frequently an intraventricular pressure gradient with diastolic values as in the ventricle, but systolic values that are more similar to the aortic pressure than to the ventricular pressure in the more proximal LV cavity. If you suspect a high output state, you need to think of the causes of a high output state and exclude them. Anemia, fever, beriberi, arteriovenous fistula, patent ductus, aortic regurgitation, hyperthyroidism, cirrhosis, and some others. The next discordant pattern is when the valve area and dimensionless index are in the severe range, but the gradients are in the mild or moderate range. Now, this may be due to a technical underestimation of flow velocity or gradient. If your angle of incidence, insonation, insonification, those are all words used for the angle of incidence of the Doppler beam relative to direction of flow. If that is more than 30 degrees off parallel, then you may underestimate significantly the flow velocity and gradient. Or it may be that you've estimated the flow velocity and gradient accurately, but that there is indeed low flow and low gradient, left leg, low flow, low gradient associated with the aortic stenosis. So the first thing you want to do is exclude an excessive insonation angle. The second is you want to exclude what is called now classical left leg, classical low flow, low gradient aortic stenosis. Used to be called left ref, low flow reduced function aortic stenosis, because the classical form is due to LV systolic dysfunction. If that's not present, then you want to exclude paradoxical low flow, low gradient aortic stenosis. Used to be called left neph aortic stenosis, low flow normal function aortic stenosis. So first of all, if you suspect an excessive insonification angle of more than 30 degrees, if the insonification angle is more than 30 degrees, you're going to is 30 degrees, you're going to get a 14% error in velocity and a 23% error in gradient, because that is squared. Okay. So then what do? You go back and you look at the transthoracic echo, and you may be able to say, well, they didn't look from the suprasternal or the right parasternal view. We better get additional data to see if we can better align the Doppler beam with the direction of flow. If that's not possible, you may say, well, let's go to TEE and determine the aortic valve area by planimetry, as validated by Natisa Pandian from Tufts many years ago. And maybe at that time, we can also better define the anatomic pathology of the valve, and we can decide whether we want to diagnose this to be severe aortic stenosis. Remember, that diagnosis is in your hands. You are not a servant of the data that you acquire. You have to make a judgment call on those data. Finally, you can go to the cardiac catheterization laboratory to determine transaortic gradients more accurately. If you suspect classical left leg, low flow reduced function aortic stenosis, you can suspect that when the LVEF is less than 50% and the stroke volume index less than 35 mils per meter squared, consider a dobutamine stress echocardiogram. The objective of the dobutamine stress echocardiogram, the first objective, is to get those gradients and flows within a range that satisfies the premises of having a mean gradient of 40 or a peak instantaneous velocity of more than 4. But just remember, even if you don't achieve those numbers, the dobutamine stress echocardiogram at least increases pressure and flow. Because you should see here from this slide that at low flow and low pressure values, the 95% confidence intervals for each flow estimate and each pressure estimate may overlap for significantly different aortic valve orifice areas. So your ability to discriminate between severe AS and moderate AS is increased if you increase flow and gradient across that valve. Now, if you suspect paradoxical low flow, low gradient aortic stenosis, that's low flow with normal function aortic stenosis, you'll suspect that when the LVEF is more than 50% and the stroke volume index is less than 35 mils per meter squared. In that case, you first need to identify a cause. And the three causes are a small LV cavity due to intravascular volume depletion or marked LV hypertrophy in elderly females, especially with aortic stenosis, or restrictive cardiopathy, versus reduced filling that may be due to moderate or severe mitral stenosis, atrial fibrillation with rapid ventricular response rate, right-left interaction due to tricuspid regurg or pulmonary hypertension, wide left bundle branch block impinging on the diastolic filling period. Or you may have the last cause being reduced forward flow due to moderate or severe mitral regurgitation, where the ventricle has got a normal filling volume of blood, but half of the blood is going back into the atrium rather than across the aortic valve. Now, in these patients, in these cases, the most critical issue is your decision that transaortic flow volume or stroke volume is reduced. And so therefore, the best thing to do here is to use an alternative method to confirm that suspicion and to determine cardiac output and stroke volume in another way, non-invasively using cardiac MR, or you can use a thermodilution catheter. And then you can determine aortic valve area as the cardiac output divided by the square root of the mean gradient. I'm sure at this stage, those of you who are writing the boards are all familiar with the Hucke equation that's used frequently in the catheterization laboratory. Where do you get your mean gradient from if you used cardiac MR to determine the cardiac output? You get that from the Doppler echocardiographic data. Or you can determine the aortic valve area as the stroke volume divided by the VTI across the aortic valve using the same formula as used in the continuity equation. The third pattern of discordance is this pattern, where the aortic valve orifice area is very low, but neither the dimensionless index, nor the mean gradient, nor the peak velocity are in the severe stenosis range. The explanation for that is an underestimation of LVOT diameter. And you suspect this when you've got a dimensionless index of more than 0.3, with an LVEF of more than 50, an LV internal dimension of more than 40, and a stroke volume index of less than 35. And then you can consider using the CT angiogram data. Many of these patients are going for TAVRs, and you have CT angiography performed routinely. And you can use those CTA data to determine the cross-sectional area of the LVOT by a different method, and then multiply that by the Doppler velocity index, as we explained earlier, to determine aortic valve area by the continuity equation. You can use a TEE to reassess the LVOT diameter, or you can go to cardiac catheterization and measure aortic valve area in that way. And finally, the last discordant pattern is a pattern where the dimensionless index, mean gradient, and peak velocity are in the severe range, but the aortic valve area is not. What is the reason for that? Well, it's overestimation of the LVOT diameter. So if the LVOT diameter is overestimated, the aortic valve area may not be severe. But that's why it's always important when you find that pattern to first determine the aortic valve area index. Because if you've got a very large patient and your aortic valve area index comes to less than 0.6 centimeters squared per meter squared, you can consider the data concordant for severe aortic stenosis. But if the aortic valve area index is more than 0.6 centimeters squared per meter squared, then you have overestimated the LVOT diameter. And the way that you resolve that is exactly the same way that you resolved underestimation of aortic of LVOT diameter that I described earlier. Now, if the hemodynamic parameters are concordant, as I've said earlier, you manage according to GDMT. If the parameters are discordant by TTE, further diagnostic workup is required, and this may include transesophageal echo, dobutamine stress echo, cardiac catheterization, CTA, or cardiac MR imaging, as detailed above. Now, there are additional supplementary tests that you need to consider. First of all is exercise stress testing in selected patients, and this can be used to elicit covered symptoms, to elicit reduced exercise capacity, to assess the blood pressure response, and the test is considered very positive if the patient fails to mount an increasing blood pressure response to exercise, or even more so if the blood pressure declines with exercise. And using hemodynamic stress echo, you can also assess the LV functional response. The other stress testing that you can do, we've already alluded to, which is dobutamine stress echocardiography, to confirm the diagnosis in patients with classical left leg aortic stenosis, also called left ref, low flow reduced function aortic stenosis. In addition, I think this talk would be incomplete without spending just a minute or two on the coronary angiogram or CCTA in these patients. This can be used to exclude obstructive coronary artery disease as a cause of symptoms. It can be used to exclude obstructive coronary artery disease prior to stress testing. And in our laboratory, we mandate that a patient must have had a coronary angiogram within at most a year prior to subjecting them to stress testing if you really truly suspect severe aortic stenosis. Because if there is life-threatening underlying coronary artery disease and you induce ischemia in a patient with severe or even critical aortic stenosis and they decompensate, it's often very difficult to get them back. To assess coronary artery anatomy prior to transcatheter or surgical aortic valve intervention. So here you've decided there's severe AS, but you want to see the coronary anatomy because it might make a difference in the decision whether to do TAVR or SAVR, because you might want to intervene on a coronary artery. Let's get to natural history, just a few slides on that. Aortic sclerosis, but it's important to know the natural history because as a physician, you are going to have to tailor your treatment to your projection of what's going to happen to the patient if you don't intervene. So patients with aortic sclerosis without stenosis, 16% of them will develop mild stenosis at a year. 2.5 of them will develop severe stenosis at 8 years. Patients with asymptomatic severe aortic stenosis, the overall sudden cardiac death rate is low, less than 1% per year, but the 5-year event-free survival is only 20% if there's severe sclerosis, but is 75% if there's mild sclerosis. And that's why looking at the sclerosis in addition to the stenosis is important. And I know you guys are probably familiar with the CT work that's being done, looking at the prognostic value of calcium on the aortic valve. And finally, in patients with symptomatic severe aortic stenosis, and remember, I told you I want you to differentiate the non-specific symptoms from those symptoms that are the harbingers of sudden cardiac death. So in patients with systolic heart failure that have got dyspnea because the LVEF is less than 50% in addition to the diastolic heart failure that many of them have, the 2-year median survival, the median survival is only 2 years. If they have syncope, the median survival is 3 years. And with angina, the median survival is 5 years. And those are the harbingers of sudden cardiac death. The average rate of decrease in aortic valve area that you can expect and that you can predict to your patients is something like 0.1 centimeter squared per year. You understand that if you've got an aortic valve orifice area of 2.1 square centimeters or 2 square centimeters, it doesn't matter in a year whether it's 1.9. But if your aortic valve area was 1.0 square centimeters, then it may become very important. Factors that accelerate progression are older age, the degree of sclerosis or calcification, as we said, renal insufficiency, hypertension, cigarette smoking, and dyslipidemia. So you want to control those in all your patients. And now we get to management. First of all, the patients need to be educated. They need to report onset of symptoms promptly. They need to be informed which symptoms are the harbingers of sudden cardiac death. You need to treat their coronary artery disease risk factors energetically. And if the stenosis is severe, but you're not going to intervene on the valve, they should avoid vigorous physical activity. The Doppler echocardiographic follow-up is 6 to 12 monthly if severe, annually if moderate, and if it's mild, it becomes a judgment call. Now, surgical or interventional management, according to the guidelines, aortic valve replacement is indicated as a class 1 indication if you have severe symptomatic aortic stenosis. What's become a little bit muddy is the definition of the symptomatic component of that statement, because we are certainly doing a lot more TAVRs than we used to do SAVRs in days gone by, and many of these patients are minimally symptomatic, in my opinion. Now, aortic valve replacement is reasonable in paradoxical, low flow, low gradient aortic stenosis. That, remember, that's when the gradient and the flow are low, but LV systolic function is normal. It's reasonable provided clinical, hemodynamic, and anatomic data support valve obstruction as the most likely cause of symptoms, and that's in the latest guidelines. Now, aortic valve replacement is also recommended as a class 1 indication if LV ejection fraction is less than 50%, because in those patients, you've got a median survival of only 2 years. It's indicated as a class 1 indication if you're going to do concomitant CABG or other heart surgery in a patient with severe aortic stenosis. Of course, you should replace the aortic valve at the same time. It's a class 1 indication if there's an abnormal response to exercise testing. And the reason for that is that in asymptomatic severe aortic stenosis, a positive stress test indicates a much worse survival. As shown in this publication by Amato from way back in 2001, event-free survival in patients with a negative stress test was way better than those with a positive stress test. It's a class 2A indication in asymptomatic severe AS If the AS is very severe or critical as defined by an aortic valve area of less than 0.7 centimeters squared, or if the peak instantaneous gradient is more than 100 millimeters mercury, meaning the peak instantaneous velocity across the valve is more than 5 meters per second. Why, if it's more severe, do we feel that we're more justified in going to surgery? Well, it's this study from Rosenheck and others in 2010, showing that the event-free survival of very severe aortic stenosis is not as good as severe aortic stenosis. So you can see when the peak instantaneous gradient goes up from 64 in the yellow to 100 in the red to 120 in the orange, survival progressively decreases. And finally, if you have severe aortic stenosis or moderate to severe aortic stenosis, and it is progressing rapidly with aortic valve area decreasing at more than 0.2 centimeters squared per year, if you can guarantee a surgical mortality of less than 1% from your own data, so in other words, there's a low operative risk, then you can consider proceeding with aortic valve surgery. And finally, because I think it is important to expose you to global longitudinal strain, I'm going to show you how that has been putatively introduced into the algorithm for early intervention on aortic stenosis, although this is not yet guideline certified and may never be, for all I know. So this graph shows the survival free from major adverse cardiac events in asymptomatic severe aortic stenosis with an LV ejection fraction more than 50%, the group on whom you would not usually intervene. And note that measuring global longitudinal strain predicts major adverse cardiac event-free survival in asymptomatic severe aortic stenosis, even when LV systolic function is preserved. If GLS in this particular study was less than minus 17%, survival was good. In other words, minus 19. It's always confusing this because it's a negative number. If GLS was more than minus 17%, let's say minus 14, survival was worse. This is a separate paper showing you similar information. And this shows that GLS identifies a subset of patients with asymptomatic severe aortic stenosis and normal LVEF who are at increased risk of sudden death if the GLS was greater than minus 14%, let's say minus 12% in this study, then the outlook was almost as bad as if they had an LVEF of less than 50%, which means a 2-year median survival. And why this may become important is the key or the trick with aortic stenosis is to know when to operate, because you don't want to wake up with a dead patient that you were waiting for the stenosis to progress a little more. So here's how we could putatively incorporate these data into the current algorithm. So the current algorithm says that if you've got asymptomatic severe aortic stenosis, your LVEF is less than 50%, Vmax, peak velocity more than 5 meters per second, valve area less than 0.7 centimeters squared, poor exercise tolerance or rapid progression, you can consider TAVR or SAVR if not contraindicated by comorbidities. If that's not the case, we currently suggest that you go on with medical therapy with a 6-month or annual echo. But now we say if it's not the case, maybe we should look at global longitudinal strain. And if it's greater than an arbitrary value, you'll see I put 16% because this is just arbitrary on this image, because the two ranges or thresholds in the previous two studies were 17 and 14. If it's greater than minus 16%, or if, as in the cardio-oncology literature, it changes by an absolute value of more than 3%, perhaps we should consider earlier intervention. Okay, and with that, I don't know if there's time for questions. There's only 4 minutes. I'm going to ask Jay if he wants me to go on with the questions.
Please go on with the questions, Dr. Marcus.
All right. So first of all, we have a patient in whom a systolic murmur was detected at the left sternal border, who is referred for Doppler echocardiographic examination, which shows an aortic valve orifice area of 0.8 square centimeters in the severe range, don't forget, by continuity equation, with a transaortic mean systolic gradient of 18 millimeters mercury, remembering our matrix that's in the mild range, and a dimensionless index of 0.45, also in the mild range. Which of the following is the likeliest diagnosis? Severe aortic stenosis with severe mitral regurgitation, mild aortic stenosis with underestimation of LVOT diameter, severe aortic stenosis with LV ejection fraction less than 50%, or severe aortic stenosis with small cavity and low transaortic flow. I hope you guys can see, guys and girls can see. Goodness, my daughter told me not to call you girls, but rather women. I hope everybody can see that A, B, and D are asking you, do you think that this could be a form of left leg aortic stenosis? Because those are all mechanisms for left leg aortic stenosis. A, C, and D. B is the only one that says aortic stenosis is mild with underestimation of LVOT diameter. And B is the correct answer, because with any of the others, you would have expected a dimensionless index of less than 0.3 in our laboratory or less than 0.25 in the ASC laboratory. Okay, let's go on to the next question. Which of the following causes of aortic stenosis is or are associated with aortopathy? Bicuspid aortic valve, unicuspid aortic valve, supravalvular aortic stenosis, subvalvular aortic stenosis. A is correct, and B are correct, A, B, and C are correct, or all are correct. Well, the correct answer is 3. Bicuspid and unicuspid aortic valves are associated with cystic medial necrosis, causing an aortopathy in 25% of cases. Supravalvular aortic stenosis is associated with elastin arteriopathy due to a microdeletion or mutation in the elastin gene on chromosome 7. Now remember also, it's just interesting to think that supravalvular aortic stenosis is associated with bicuspid aortic valve in 50% of cases, whereas the general population has bicuspid aortic valve in only 1 to 2% of cases. I'm repeating all of this because I wanted to get inside your heads so that not only do you know it for the future, but you know it for the exam. Subvalvular aortic stenosis is not associated with an arteriopathy usually. Now, next question. Causes of low flow, low gradient in a patient with severe aortic stenosis, because this question can be misunderstood, include severe mitral regurgitation, severe tricuspid regurgitation, LV systolic dysfunction, underestimation of LVOT diameter. Only A is correct, A and B are correct, A, B, and C are correct, or all are correct. The answer is 3. A, B, and C are correct. Severe mitral regurgitation is a cause of left leg, low flow, low gradient, severe aortic stenosis, because a lot of the flow that enters the left ventricle goes back into the left atrium, and the forward stroke volume is not infrequently less than 35 mils per meter squared, which defines the low flow, low gradient aortic stenosis group. Severe tricuspid regurgitation may cause marked right-left interaction, impairing left ventricular filling, resulting in a decreased forward flow with a stroke volume of less than 35 ml per meter squared. That number's coming up in your exam. And LV systolic dysfunction, of course, with an EF of less than 50% may do the same thing. Underestimation of LVOT diameter can cause a spuriously low estimation of flow. It should not affect the gradient, the peak transaortic gradient, but it can cause a low flow. But we've said here in patients with severe aortic stenosis, and underestimation of LVOT diameter does not cause low flow and low gradient in those patients. Next one. And this is a bit of a long stem, but I think it's the most interesting. And when it's done, you're welcome to take your leave, but afterwards I've got a beautiful case to show you that uses these findings. 3 questions. Okay. A 72-year-old female patient with mild rheumatic aortic stenosis underwent mitral valve replacement with a 27mm stented xenograft for treatment of symptomatic severe rheumatic mitral regurgitation and stenosis. 10 years later, she presented with increasing exertional dyspnea and a prominent systolic murmur both at the apex and at the left sternal border. Transthoracic echo revealed a peak transaortic velocity of 4.5 meters per second, a mean transaortic systolic gradient of 45 millimeters mercury, a Doppler velocity index of 0.40, an aortic valve orifice area of 1.5 centimeters squared, and apparent mild mitral regurgitation. Apparent mild mitral regurgitation based on transthoracic echocardiogram across a stented xenograft. I trust everybody knows what a stented xenograft looks like. What is the most likely explanation for these findings? Severe rheumatic aortic stenosis, hemodynamically significant mitral regurgitation, subvalvular LVOT gradient, and mild aortic stenosis, severe mitral regurgitation with mistaken location of systolic gradients and no aortic stenosis, or overestimation of LVOT diameter with severe aortic stenosis. Well, immediately I tell you that the Doppler velocity index is 0.4. We are telling you that it is not severe aortic stenosis. So A is excluded and D is excluded. In addition, in point C, we say there's no aortic stenosis. If there's no aortic stenosis, then there's no reason for the Doppler velocity index to be below 0.5 or actually below 0.6. So the value of 0.4 tells you that there must be some degree of aortic stenosis. So you're left with B. And we say hemodynamically significant mitral regurgitation, not because of the Doppler echocardiographic data here, but because we told you that 10 years ago, the patient had a stented xenograft put in place, and it would be very predictable that that graft might degenerate, resulting in severe mitral regurgitation, producing a systolic murmur at the apex and accounting for exertional dyspnea. So well, my point to you is I want you to integrate the Doppler echocardiographic and clinical findings and come up with a diagnosis. Another point I just want to make before I finish here is you can mistake LVOT gradients for severe mitral regurgitation and vice versa. And obviously over the years I've been practicing, I've seen that done on several occasions. So beware when you call a gradient across the LVOT from the apical imaging plane that you're not actually looking at flow going across the aortic valve, going across the mitral valve, which is coming in the same direction, regurgitant flow across the mitral valve. I hope that's clear to you. Okay, questions. Okay. Okay, so I'm being prompted by my caregiver here, Kofi, who's a marvelous fellow working with me, who's the one that put me up to this talk in the first place, that there's some questions to be answered. So Jay, let me turn it over to you. I know I'm late.
No, I'll be asking the questions.
Oh.
Thank you, Dr. Marcus, for your very exhaustive talk here. We have two questions. The first one is, what is the utility of peak aortic gradient in evaluating aortic stenosis? And why do we still check it, even though the guidelines, it's not part of the parameters we use to assess for severe aortic stenosis?
Well, a peak instantaneous value of more than 4 meters per second, a peak instantaneous gradient of more than is one of the 4 Doppler parameters that does help you identify the severity of the aortic stenosis. You
mentioned the peak gradient.
Did I?
Why do we?
Wait a minute. Sorry, if I said that. Okay, so what I meant by that was I guess it was a turn of phrase. The peak instantaneous velocity, which is a physiologic parameter, always correlates with the gradient, because all you have to do is apply the modified Bernoulli equation to that velocity and you get a gradient. So the parameter of severe aortic stenosis is a peak instantaneous velocity of 4 meters per second. That correlates 4b squared with a peak instantaneous gradient of 100 millimeters of mercury. So maybe I misled you by the way I expressed that, but does that explain the answer to your question?
Yeah.
Okay.
Okay. Right. So, and then the second question was, when should TE surveillance, how often should TE surveillance be done after post-surgical aortic valve replacement?
So following surgical aortic valve replacement, there isn't a routine guideline dictating that you should do you said transesophageal echo?
Transthoracic.
Oh, transthoracic. Oh, okay. So after prosthetic valve replacement, if you've got a mechanical valve, you should have a look at it, preferably within 6 months to a year of it being put in. But after that, if the patient has no problem, the guidelines do not mandate that you do repeated assessment of a mechanical valve. However, just having been in practice, I guess I'm repeating myself like a broken record for all these years. The patient may come in one day, you might think the gradient's a little bit more. As the patients get older, and many of these are elderly patients, they tell you they're a little bit more short of breath. So if there's any intervening or interim development of any symptom, they get a little bit of swelling of the legs, whatever happens, they feel a little bit lightheaded, you know, I've got a very low threshold to go back. But if the patient is entirely asymptomatic, you should check the valve once and you don't have to really check it again. With a bioprosthetic valve, it's more of a gray area. You definitely need to check it once. But as you know, they still say that 10 years after implantation of that valve, 50% of them are degenerating. And so you should go back and check it at intervals. Certainly, if there's interim development of symptoms, you should check it. Certainly, you should not leave more than 5 years to check it. My own wont is to check that valve every 2 to 3 years, even in absence of any symptoms.
All right. Thank you, Dr. Marcus. We do have additional questions, but for the lack of time, we will email these questions to Dr. Marcus and we'll post them.
If it's just a few questions, Kofi, I think we should just go ahead maybe.
Okay, then.
Yeah. Because it'll be recorded and people can watch them later. So it should be fine.
Okay, so the next question is, can you explain the pressure recovery phenomenon associated with?
Yeah, I perseverated onto whether or not to include that in the talk because really it's better explained with diagrams. I know that I thought I saw on your syllabus, and Dr. Ashworth, correct me if I'm wrong, that there is going to be a talk on the details of hemodynamics. I am going to speak to this a little bit, but not exhaustively. Is that correct? That somebody is going to... No. Okay.
Yes,
so
we will have hemodynamics. I don't know if they'll cover pressure recovery, but yes. So if you want to mention a few points, I think that will be great, Rick.
So pressure recovery occurs when the flow across the valve goes into eddies on the distal, that when there's a lot of turbulence and the flow forms eddies that result in drop off in pressure in the proximal aorta and aortic root, proximal to where you might place a catheter in the catheterization laboratory. And then that pressure recovers as the flow comes back into the aorta, so that in the more distal aorta, that pressure has recovered to some extent. Now, when you use Doppler, let's say continuous wave Doppler, to assess the flow across the aortic valve, you get the maximal pressure gradient. So you get this area of, it's not right to say in physics terms of vacuum, but let's pretend that you've almost got a vacuum just distal to the valve because of these airy eddies and these sort of Venturi effects just distal to the valve leaflets. And the anatomy and eccentricity of the jet can contribute to this. So the CW Doppler gives you the absolute peak gradient. When that blood comes back into a more laminar flow in the proximal aorta, the pressure recovers a bit. So if you've got a catheter in the proximal aorta and you've got a catheter in the left ventricle, you may miss the difference in pressure between the left ventricular pressure and the pressure in the proximal aorta that was occurring in that area where the pressure dropped further before it recovered. It's very difficult to explain it like this without some images to show what we're talking about. But I hope that makes some sense to you.
All right, thank you, Dr. Marcus. We have one more question here. Does your lab use predicted valve areas in discordant cases?
Just repeat that. Does the lab use?
So does your echo lab use predicted, aortic valve area in these discordant cases?
What do you mean by predicted? Maybe I'm not understanding.
Projected
valve areas. Yeah. So I can tell you that we don't do that as a standardized, in a standardized format type way in the laboratory, because I think it lends itself, I was going to say to abuse. I don't mean abuse. I mean, it lends itself to error, but I can assure you that within my own mind, where these numbers are running around and buzzing all the time, I do those things, and I do assess what I think the valve area might be and what is being projected by the data. But we don't have a standardized format and tabulation of that information in our laboratory.
Thank you, Dr. Marcus. Yeah, I think that's all the questions we have for now. Back to you.
Rick, I pulled up a picture of the pressure recovery phenomena, if that helps you, because I think that's very highlighted on the boards. And I know you're an expert in this area. So
sorry, I
just pulled up a picture of the pressure recovery phenomena and shared it in case you wanted to use that to explain it anymore, or it's up to you. Because I know this is kind of high yield on the boards, and
I can't see it.
Kofi, can you see that?
I'm supposed to be seeing it on my page.
We'll have to stop sharing Dr. Marcus's screen, and then you have to
okay.
start sharing yours.
Okay.
I think we can finish Dr. Marcus's this case, and okay, yeah, we see it now.
You see it now? Okay.
Okay, so I'm trying to see. Okay, so here, if we look at this, let me see if I double click on this one here.
It didn't open up big, so.
Okay, all right, okay. So if you look at the top right-hand panel, you see it, the left ventricle in a sort of parasternal long axis image plane. If you consider that a tomographic image, you can see the arrow showing you flow across the aortic valve, LV cavity, and the effective orifice area, okay? And if you look at the bottom, below that, you'll see a curve that shows pressure on the vertical axis and time on the horizontal axis. And you can see that flow, the pressure goes, I don't know how well you can see this, but I can see it on my screen. You can see that as on the left-hand panel, as the flow goes out across the aortic valve, the pressure in the LVOT, or in the left ventricle, let's say, the left ventricle was 170 millimeters mercury. And then that drops to a value, you see the line of 145, so let's say it drops to a value of about 70. That would give you a peak, although it's not instantaneous, because now we're talking about peak to peak. So the diagram is not quite good enough for me, but anyway, it would give you a pressure gradient there of, let's say, somewhere around 100 millimeters of mercury. The pressure then recovers, and I don't have images here to show you the physics of that, but anyhow, the pressure then recovers to a value of 145. So the gradient between the left ventricle and the proximal aorta there would be 170 minus 145, which would be 25 millimeters. Whereas the gradient measured by CW Doppler on that left image would be 170 minus somewhere in the region of 70, which would be 100 millimeters. So there you're having a pressure recovery of about 55 millimeters or so. And I think I'm just going to leave it at that, if that makes some sense to you.
That sounds very good. Jay, if you want to just share the lectures from tomorrow. Thank you very much, Rick, for the great talk. Excellent lectures, as we're getting multiple feedbacks already. So thank you very much for your expertise. Thank you all for joining us today on a Saturday. Tomorrow we'll have lectures again from 9 to 1. Look forward to seeing you. If you have colleagues who are interested, for instance, anesthesia, emergency, or ICU, or whoever is interested in POCUS, feel free to share the information with them. If you are missing any of the Zoom links or anything, feel free to reach out to me or to Jay, Kofi, or any of us, and we'll be happy to share this over to you guys, Dr. Roy. So I look forward to seeing you all. Enjoy the rest of the day. Take care. Bye-bye.
Hey Jay, are you still there?
Yes.